bronchioles as an adult, correct?
Sure, it could be.
Immune system's not as built up as an adult.
Yeah, our immune system's not as advanced, and we'll talk about kind of some of those mile markers that talk about our immune system. So our immune system's not as advanced. What else?
Their airways are smaller, easier to get congested.
Yeah, airways are smaller, and in fact, the book really talks about them being pliable, so they're softer. They're not as firm, and so things that we traditionally think of that cause inflammation, that squeezes in on the respiratory tract, where you and I would probably have some inflammation, it could completely occlude the airway in a smaller child. Other things that could also affect it are that they've not been exposed to a lot of things, right? So the more times we're exposed to different things, we kind of build up antibodies, and we build up a certain type of immunity just by being exposed to certain viruses or certain types of things that we come in contact with. So especially the younger child may not be around as many adults or children outside of the home. Can you see my PowerPoint now?
Yes.
Okay, wonderful, thank you. All right. So this is where we talk about aspects of respiratory infections, and these terms are going to sound familiar. So talking about upper respiratory, and so upper respiratory is looking at really the upper trachea on up. And if we have an upper respiratory infection and we think about that, we have signs and symptoms of things that are like a sore throat. They could be hoarseness or difficulty talking, could be allergy symptoms like sneezing and nasal drainage. And then we think about the lower respiratory tract, we think more about the lungs. Okay, and so when we think also about the lower respiratory tract, we think more about gas exchange. So lower respiratory tract, again, could be inflammation. It could be obstruction, either from something like mucus or inflammation, even squeezing in, like something like asthma. It could be an infectious process like pneumonia or TB. And it can even result in long-term complications of emphysema, where we're talking about the alveoli not being able to expand as much in as much room as gas exchange. So a lot of the things we've talked about, when we think about these disease processes, these are also things that we think about with children's infections. Okay? And there's really a third kind of a classification that's called croup symptoms. Now, I don't want you to think about croup as a disease process. I want you to think about it as symptoms or syndromes, and we'll talk a little bit more about that. But there are infections of areas of the epiglottis and the larynx. And so what I think really about the larynx is your voice box. So you get hoarse, narrowing of that can cause things like stridor or a high-pitched kind of a wheezing sound. So we'll look at those kind of symptoms as well. One of the things that's important to remember as well as we classify disorders based on where the primary kind of predominant symptoms are. But we know that there's not a gateway that stops entry from one part to the other and prevents things from moving from one place to the other. So we can also think about disease processes that are predominantly in one area, but we could also have symptoms in another area. And then some disease processes like an upper respiratory infection, sinusitis, that kind of thing, the bacteria can move along the walls of the bronchial tubes, the fine epidermis and the bronchial tubes, and it can migrate to different parts. So a sinusitis could potentially have infection and infect the lining of the, any of the respiratory tract and move its way down and cause a lower respiratory tract infection. Okay? So these are really the differences between children and adults. And I want you to understand too, that a lot of these things, we're not only talking about difference in children and adults, but even from one age group to another. So many of these things are more predominant in the very young child, of course, than the older child, adolescent. So how are respiratory tracts in general different from children and adults? And so we said that it could be how they're breathing. And so let's think about this. If we're an adult, we're using our respiratory tract to take in big deep breaths and get it all the way down to our alveoli. Well, that takes a lot of different things. We could either breathe through our nose, and if it gets stuffed up, we can breathe through our mouth. We use our diaphragm to really help expand our lungs. And we also use positioning too, don't we? Particularly if you're sick and you got a stuffed up nose, then you position yourself either sitting up or elevated on pillows to help you be able to expand your lungs more. A lot of those things the very young child can't do. So particularly if we're thinking about obligate nose breathers, that means that children 6 weeks and under can only breathe through their nose. They can't breathe through their mouth. They don't have the musculature to take in those big deep breaths through their mouth. So that means that we're particularly concerned about nasal secretions building up in children that are very, very young. So some things we can do, and when we think about disorders, we think about how the respiratory tract is in children and also the signs and symptoms. I want you to think about, well, okay, if they're having that symptom of nasal stuffiness, how can we help that? How can we fix that? And that's going to be some of our nursing interventions. So if we have that nasal drainage, particularly in a young child that can't blow their nose, we're going to use a bulb suction and suction that out. If we have really thick secretions, we may even use some humidified oxygen. The moisture in that humidification can help break down those secretions. And then we can think about the very young child as well with those secretions, with that thick mucus, having a risk for things like airway obstruction, aspiration. We've got the short neck. Short neck means distance from the nose, the outside world, all the way to the bottom of our lungs. So they're much more likely to have things like bacteria and viruses, as well as foreign objects, which we'll talk about, that go from places like their nose, mouth, down into their lungs very quickly. They have a shorter, smaller, narrower airway. Okay. In addition to that, it's shorter, it's more narrow, more likely to be affected by inflammation and to get things trapped in there, more susceptible to obstruction, and can progress to respiratory distress very quickly. So we have to be able to recognize symptoms in a child that's having respiratory distress. Like I said, you and I, what we would traditionally think of is, oh, I start breathing through my mouth. I want to sit up, probably in a tripod position. I may start panting. I may start telling you I'm having shortness of breath. All those things that the very young child can't do. So what are some symptoms that the young child is having problems with their respiratory system?
Nasal flaring.
Yeah, so if I'm breathing through my nose, that nasal flaring, that increased effort of trying to get air in. What else?
Accessory muscles.
Yeah, accessory muscles. So we can think of the neck, the chest. Okay. Again, we can't use that big diaphragm. We're using those muscles that are kind of substernal. What else?
Cyanosis.
Yeah. So we're definitely going to see a very quick progression from inability to take in oxygen to affecting gas exchange. So we think of the child that's pale, the child that has cyanosis around the lips. We could also look at the mucous membranes. Okay, there can even be kind of a bluing of the mucous membranes, especially in children with darker skin. What else?
Intercostal retractions.
Yeah, so intercostal retractions, the difficulty in breathing.
Seesaw respirations.
Seesaw respiration. So their increased effort may give them not only increased rate of respirations, but irregular respirations. Okay. We can also look at the alertness of the child. Are they becoming lethargic? Are they difficult to arouse? When we think about the older infant, we can think about diuresis. Okay. We also want to, when we think about interventions, we want to think about how do we keep them calm? Okay, we think about all these things going on. Crying increases difficulty in breathing. So we know that if they're coming in, if we're assessing those kind of things, we want to keep them calm. And if that means mom's holding them when we're assessing them, or mom is kind of standing by them when they're on the table and we're assessing them, keeping them calm is important. And again, if we have a child that's having trouble breathing and they're taken away from mom, or they're not with mom and they're not responding, then that means all their effort is going toward breathing. Okay. In smaller children, particularly, the tongue is larger in proportion to the mouth. Okay. Again, that's likely to occlude the airway in an unconscious child. And then the trachea is much more pliable. Like we said, we're thinking about mucus inflammation on the inside of the respiratory tract, but also thinking about inflammation on the outside of the respiratory tract. Things like asthma, things like an anaphylactic reaction can squeeze on the airway, the trachea. And if it's pliable, if it's soft, it's much more likely to obstruct it than an older adolescent to adult that their trachea is more firm.
It's also shaped like a funnel, isn't it?
Yes, yes. So the likelihood of secretions kind of pooling in the trachea is much more likely as well. And we know that particularly the younger child, what is that cough effort like? Other things that I thought of, in addition to strength of the muscles and the diaphragm, we talked about positioning. So we know that we can sit them up, but we can even think about elevating the head of the crib for children that have stuffiness, that are having some particularly upper airway, like a respiratory virus or infection. Thinking about coughing, again, is the child coughing or able to cough? Deep breathing, so watching their breathing, and then knowing that we prevent things like pneumonia and lower lobe infections by teaching patients to cough and deep breathe and using an ascending spirometer, things that the very small child isn't able to understand to do or to be able to do. And then we have to think about preventing the spread of infection. So when we think about how to treat children, we also have to think about teaching parents how to prevent infection. So how do we think about preventing infection?
Hand washing.
Hand washing, sure. What else?
Keeping them home when they're sick.
Yeah, keep them home when they're sick. Stay away from other people who you can spread the infection to. Another thing that's important we'll talk about is immunizations. A lot of the respiratory virus infections, things we'll talk about, to prevent serious complications, we need to make sure they're getting immunizations on a timely manner. Okay. All right. So when we think about infectious agents, we're talking kind of like globally about different things that could cause infections. And these could be viruses or bacteria. So viruses, we'll talk about one of the most common is RSV, respiratory syncytial virus. But then there's also bacteria. There's group A beta hemolytic strep, which we've mentioned before. There's staphylococci, which is common on surfaces. Usually that staph, we can be found in wounds and also on the outside of our skin. But we know that toddlers, infants, everything is hand to mouth. So we could be touching things that have bacteria on them that can go into the mouth. Also thinking about the way things are spread between children is toys that they put in their mouth and spread from one toy, as well as things like cups and eating utensils and all those things that could be shared in families with children drinking after each other, that kind of thing. Other types of bacteria can be Chlamydia trichomonas, it can be mycoplasma organisms, pneumococci, Haemophilus influenza B. Again, many of these things that we talk about getting immunizations. Okay. So the cause of respiratory infections, we said, varies by a number of things. It varies by age. Again, we're talking about the toddler putting their hands in their mouth versus the school-age child, which we should be teaching to cover their cough, to stay home. Keeping them home if they are sick. They're probably not at the age where they're putting their hands in their mouth a lot, but even teaching them not to touch their eyes and mouth after they've coughed or sneezed and washed their hands, those type of things. So the age group can affect their susceptibility to getting ill and behaviors that we can teach to stay healthy. Also could be affected by living conditions. So things like pollution, dust, ventilation in the home, secondhand smoke, all those things can affect respiratory illnesses, course of infection. So the rate of progression of going from sick to very sick, or like we said, children that are older who have built up immunity and have had vaccinations probably aren't going to progress to the very severe sickness in many cases unless they haven't been vaccinated or unless they haven't been treated. Okay. And then pre-existing medical conditions, of course, anything that has to do with decreased immunity, pre-existing respiratory conditions, some cardiac conditions, all those can predispose a child to more frequent respiratory infections and more serious respiratory infections. So age, we talked about immunity, and up until about 3 months of age, their maternal antibodies that they still are carrying can protect them. Well, we know that infants start producing their own antibodies at about 6 months. So we have a gap there between 3 and 6 months where the infection rate increases in children. It also increases again when they start going to daycare. So toddler, preschooler, again, the high rate of viral infections, in that case, because they're being exposed to more cases of viral infections. Then there's another gap when we think about children that are about 5 years old to 7 years old, where they're starting school. Again, another possible introduction to children and interactions. And so incidents of things like group A beta hemolytic strep and types of bacterial pneumonia are more common at that age as well. And then as we get older, with our increasing immunity from immunizations, as well as being exposed to different things, then we develop more of that immunity. So clinical manifestations or signs and symptoms of respiratory infections. Again, it's going to depend on the age. And then again, we said it's going to depend on what type of a respiratory illness do we have, upper respiratory, lower respiratory. And then the signs and symptoms, we said, differ among young children. So young children many times have an increased risk for a higher fever, as well as a fever that comes on very quickly. That's really one of the first signs that their immunity is kicking in. So a higher fever. Also could be signs of general signs and symptoms, so kind of non-specific things. Anorexia. When we think about anorexia, we think about not wanting to eat. So poor feeding or not wanting to eat could be maybe because I'm just feeling kind of nauseated, or it could be because I'm having trouble breathing, right? Especially when we're talking about those obligate nose breathers, breastfeeding, bottle feeding. If I'm trying to swallow and take in a bunch of food at the same time, it's hard for me to breathe. And so not only decreased appetite, but difficulty breathing when I'm trying to take in food. So I may not want to take in food. And in that case, in addition to things such as vomiting or diarrhea, we have a real concern of looking for dehydration in children, which can progress very quickly. So their bodies are made up of much more water than we are, which means they're more dependent on water. And if they're losing that, then we have to watch for signs that they could become dehydrated. So when we think about dehydration, especially in children, we're looking at the amount that they're taking in, but we're also looking at what are other ways other than vomiting, diarrhea, they could lose fluid. So if we're not taking in fluid, we're going to be losing less fluid. So teaching parents to watch for fluid intake, but also wet diapers. How much is coming out? Also watching for things that could cause small amounts of fluid loss. Respiratory effort, we know, could cause fluid loss, as well as fever with diaphoresis can cause fever loss. All of those things kind of combining together. Abdominal pain, the older child can tell us they got a tummy ache. What might we see in an infant that's having abdominal pain?
Drawing their legs up.
Yeah. So think about that they can't really say their stomach hurts, and they're probably not going to, grip their stomach, but many times their legs will draw up, and that could indicate that they're having abdominal discomfort. Abdominal discomfort could also be from vomiting, so it could irritate the muscles of the abdomen. Then we think about a cough. looking at, is it a dry cough or a productive cough? With cough, we want to also think about other things, kind of upper respiratory, like nasal congestion, nasal blockage. Are they having nasal secretions that are clear? Are they having nasal secretions that are thicker? So again, are we able to clear their nasal passage? An older child blowing their nose, a younger child using suctioning, and then that thicker drainage in there could be causing them to have problems with their airway as well. Some of the other things that we may notice, particularly when thinking about fluid, some of the things we think about with an adult even, dry mucous membranes, looking at skin turgor, looking at things, teaching patients about tachypnea, looking at their respiratory rate, looking at their respiratory effort. Okay, that's going to increase if we're dehydrated. Again, we don't have as much of that fluid, those amount of blood cells to get oxygen around, so we're working even harder. Things like tachycardia we may notice when they come in and we're checking their vital signs, lethargy. Many times what parents will notice first thing is, you know, they had a runny nose, they had a cough, but then all of a sudden I really noticed that they just stopped playing. They just laid around, they didn't want to interact. So looking at play is an important thing too, when thinking about how ill are they? If they're not playing, if they're not wanting to interact, then they're pretty ill. But then also looking at getting better. When children start to become active and want to play, that can indicate that they're feeling better. We could also look at skin color. We talked about paleness of the lips, cyanosis, and again, looking for change in color in mucous membranes as well. Okay.
I have a
So this
question about the diaphoresis.
Yeah.
How old are they when they are able to sweat? Because they can't sweat when they're really little, can they?
They can't. They can't.
Okay.
And some infants, it could even be up to about 6 to 8 months.
Okay.
So really looking at change in skin color, many times, especially if children are becoming overheated, they can particularly get red cheeks, red face. And then that could also indicate from that change in skin color that they may be losing some heat or trying to cool off from that. We know in the hospital that we're looking for change in, or looking for dehydration and daily weight. So again, in addition to looking at intake, wet diapers, those kind of things, when the child comes in, we'd be doing a daily weight. Okay. So other factors we said that could predispose a child, or let's look at this first, respiratory sounds. What might we hear? So even thinking about sounds we may hear just observing the child versus listening to the child, parents may state that they hear some wheezing when they're breathing, either inspiratory or expiratory. They could also state that they're hearing a stridor. A stridor means a narrowing of the airway. So usually a partial obstruction of the airway, difficulty breathing. And anytime that a child has a stridor or kind of a loud, high-pitched sound with inspiration, we want them to bring them in. Usually that's where we think about it being an emergency of inflammation. Okay. So when we think about these signs and symptoms, we think, well, we're going to help them symptomatically. We're going to be looking for signs that there's complications such as dehydration, but other things are important as well. So we want to teach patients to try to keep them hydrated, right? It doesn't have to be a full bottle. It doesn't have to be a huge cup of water or a huge cup of whatever they're drinking, even small frequent amounts to keep them hydrated. Also thinking about keeping their nutrition up. Kids that don't feel well don't want to eat, but we also want to make sure that before kids get sick, trying to keep them up with good nutrition, because nutrition can help keep our immune system healthy. So if we have a child who's eating poorly, who is not getting good nutrition, they're more likely to have a weaker immune system and to get sick more frequently. Children who are preterm at birth have a decreased immune system for a longer period of time. Again, children that are exposed to things like secondhand smoke, children that enter daycare or school, have those episodic periods where they're more at risk of getting sick and opportunities to kind of build up that immune system. Other things that we may see in an infant could be grunting. So again, in addition to use of those respiratory muscles, we can also hear kind kind of sound like that, where they're actively pushing out air. Okay. And then we said accessory muscles, nasal flaring. In addition to treating those symptoms, would be treating with medications. So a number of business orders will talk about if they have a fever, maybe giving them antipyretics, things like Tylenol, ibuprofen. We don't want to give aspirin. There's an increased risk of Reye's syndrome with aspirin, so we want to avoid aspirin. Also, we may be giving things like decongestants in children of a certain age. We may be given antibiotics if they have a bacterial infection. And then if it's viral in many types of infections, especially if they're just acute exacerbations of infections, we may be treating symptoms. So again, looking for oxygenation, looking for opportunities to improve their respiratory effort, whether it be humidified oxygen, whether it be sitting them upright or the head of their crib up, or even putting them in a car seat to keep their head elevated, and keeping those nasal secretions clear. So again, a couple of these interventions: ease the respiratory effort, keeping their nose clear, making sure that we are keeping the head of their bed elevated, and then also keeping them hydrated is going to thin some of those secretions. Managing fever, that could mean that we are noting for fever and decreasing the amount of clothing or blankets or layers that they have on, giving things like antipyretics according to how they're prescribed. Again, teaching patients, especially in very young children, that they should never give medications that aren't okayed by the provider. And that includes over-the-counter medications. So if they're giving medications for an infant fever and they say, well, all I've got is this medication that I give my 3-year-old, I'll just give part of it, that's a big no-no, because medications as we get older can have ingredients that are not appropriate for the younger child, as well as the dosages. Providing rest and comfort. Again, rest and comfort could be keeping them, like we said, elevated to help breathe, having mom rock them. Humidification many times can be achieved by going in the bathroom, turning on the shower, creating a mist to help humidify their breathing. Controlling infection, again, all those things we think about, like immunizations, hand washing, keeping them away from other children. Even in the household, we think about if one child's sick, trying to prevent everybody from getting sick. So making sure that Kleenexes or anything like that, they're thrown away, that we're washing hands, that we're not allowing kids to eat or drink after each other, that we're wiping down surfaces that are frequently touched, like doorknobs and light switches and counters, all those types of things to prevent illnesses. And parents, I think, many times tend to forget that a childhood illness can easily be passed to the parent, and you can't take very good care of the rest of the family if you're sick. And so we tend not to do those things like hand washing and things when we're taking care of our own children, but it's extremely important because those infections can be passed around the home. Promoting hydration and nutrition. Again, we think primarily about hydration. So if they don't feel like eating, keeping them hydrated with small amounts of liquid, oral hydration, especially for the kid that has a bellyache or has been vomiting or diarrhea. Thinking about replacing fluid and electrolytes. Pedialyte's great. Infilite, infant formula for Pedialyte is great. If they're able to take breastfeed or formula, perfect. But we don't want to give them things like sports drinks or fruit juices or things like that, because many times if it has sugar in it, it can cause, or caffeine, it can cause increased diarrhea. Keeping them hydrated, keeping them nourished. Malnourished before kids get sick. Nourishment before kids get sick, but then thinking about keeping them with nutrition, of giving them small, frequent feedings, snacks, those kind of things, with things that are nutritive. And then providing family support and teaching as well. So teaching everything from how to take medications, making sure that they're age appropriate as well as dose appropriate, and then how to provide comfort measures and avoid infection is important. All right. So upper respiratory infections. Okay. Upper respiratory infections, many times we can think about the common cold. Again, no cure for the common cold. It's viral. It can be caused by a number of noroviruses or a number of communicable viruses, most common in winter and fall. And a number of the viruses are listed here. Fever varies with the child's age. Again, low-grade fever is common as the children are kind of preschool and older. Younger children can develop a higher fever, especially in the beginning. And again, remember, higher fever can also add to fluid loss, okay, in comfort. And then home management varies by age. So again, thinking about, is there a problem with obstruction of the airway, especially with a very, very young child? And then thinking about how long symptoms are lasting. One of the things we'll talk about with respiratory infections, especially that are viral, is that if they last for more than 7 to 10 days or a fever continues, then that could indicate that they've progressed into an additional secondary bacterial infection. Like we said, things like mucus that are in the airways, all those things can easily spread to the lower airways. It can lead to things like pneumonia. So we want to make sure that if symptoms don't improve or fever persists, that they go back to the doctor or go to the doctor even for the first time to check and see if there is some sort of a bacterial infection. Medications we might give, we said, again, antipyretics that could really increase temperature, fever, could be cough suppressants, could be expectorants, could be antihistamines. Nasal decongestants usually aren't recommended until a child is over 2 years old, because some of them can actually be very drying and can cause dehydration, especially in the very, very young child. So again, a reason why we don't want to give children's Tylenol to an infant. It's a different formulation. Okay? And then again, like we said, preventing transmission.
I went to a conference with some of the MPs that I worked with, and the rates for writing antibiotics in Kentucky are like super high. They were a stickler about not writing antibiotics. People would come in and be like, my kid's been sick for 2 days, and they would really want you to write one. And they're like, no, this is viral. You need to wait and come back. But
Yeah.
people would get nasty about it.
Yes, definitely, definitely. And I think one of the things is kind of starting back at the basics and talking about that most upper respiratory infections are spread by viruses, and by antibiotics have some kind of nasty side effects, and we don't want to take them unless it's absolutely necessary. And if 80% of upper respiratory infections are caused by a virus, antibiotics are not going to help. So I think giving parents concrete things they can do to make their kid feel better, because that's what they want. They want them to feel better. So talking to them and giving them an exact list of things to do. So like antipyretics. So things like Tylenol, acetaminophen can help with fever. It can help with inflammation. It can help with body aches, all those types of things. Talking to them about kind of humidification. So it could either be getting a humidifier, or like we said, turning on the shower and getting a mist in there can help thin secretions. It could be talking about how to stay hydrated. So getting them Pedialyte, giving them small amounts, and then things to watch for after a certain period of time. So like if we've been treating symptoms and they develop a productive cough, they develop a high fever or a fever that increases in the amount. They develop increased lethargy. So they have increased energy. They have things that could cause dehydration, like nausea, or excuse me, like vomiting, diarrhea. Those kind of things could indicate that they could need to be seen for either dehydration, bacterial infection, those kind of things. But yeah, you're right. One of the biggest things, especially with primary care providers, is avoiding antibiotic resistance. And that happens when we're treating with antibiotics when children don't have a bacterial infection. There are tests to rule out bacterial infections that are serious things we do want to treat, like group A beta hemolytic strep. such as with strep throat, we want to make sure they don't have that. And there are some specific symptoms with that. And if they do have presenting symptoms, you know, of a edematous throat with exudate, those kind of things, we want to swab and make sure they don't have it. But if it's negative, then that can indicate viral infections. And unfortunately, with viral infections, it's managing symptoms. So I totally agree with that. And I understand that the controversy is huge about parents wanting antibiotics. But I think if we talk about that, you know, this is the percentage of viral infections, and this and this and this and this is what you need to do. It's giving them something tangible other than just saying, go home and just, you know, let it pass. That seems kind of minimizing what the child's feeling, I think. Yeah. So one of those infections we'll talk about is called pharyngitis. And pharyngitis is what we, if you break it down, it's inflammation of the pharynx or inflammation of the throat. And we want to rule out strep throat. So pharyngitis is really describing a condition of inflammation of the throat. It can be caused by viruses or bacteria indeed. And we want to rule out that it's not a certain type of bacteria, which could cause more problems for the child. So an acute infectious pharyngitis or an acute sore throat can come on very quickly. We know in kids, 1 minute they're having fun, they're playing, they go to bed, they wake up in the middle of the night and they're extremely ill. So again, if it's caused by a bacteria, we want to rule out looking for that group A beta hemolytic strep. And so if we see things like in this picture of a very inflamed tonsils and pharynx or tissues around the tonsils, and many times it'll have an exudate, which is kind of that white coating we see in the picture, that could indicate a certain type of bacteria. So we'll do a throat swab, kind of the long-handled toothpicks there where we kind of have them open their mouth and we swab both sides of the throat. And then we're looking for the type of bacteria that's actually in the saliva. So with this, we know that if it is this group A beta hemolytic strep, that we want to treat that bacteria, and it is transmitted through droplets or through saliva, okay? So no eating after anyone, no drinking after them, keeping them home, and managing symptoms as well as an antibiotic with the virus. I mean, with a bacteria, antibiotic with the bacteria, symptom management with the virus. What's important when we're thinking about group A beta hemolytic strep, what we're trying to test for with a strep test, is getting rid of that bacteria. So what it can lead to is things like rheumatic fever. If group A beta hemolytic strep is not treated and it continues to proliferate in the body, we can get rheumatic fever. And rheumatic fever goes on to cause damage to the heart, the joints, the central nervous system with inflammation. And so people that have group A beta hemolytic strep that were not treated adequately can go on to have this rheumatic fever. It can also cause things like impetigo, skin infections. So that is important that we test for it. And it can also rule out again and help us to diagnose that it may be viral. Like we said, 80 to 90% of causes of this inflammation of the pharynx, inflammation of the throat, are caused by viruses. So doing that throat swab, it's a rapid test, which means that they can swab and send it to the lab and they can have the results back very quickly. If they do a swab, let's say they come to the ED or something like that and they do a swab and send it and we don't have the results back, many times they may go ahead and start an antibiotic for a 3-day dose. That will give them time to get the test back if they're going to do a culture or something like that, and be able to call and say, yeah, it is group A beta hemolytic strep. I'm going to call in a prescription for 7 more days, or to say it's not group A strep, it's viral. Go ahead and just discontinue. I'm not going to call in anymore for that. So it really depends on how quickly they get that throat swab back, of whether they can determine right then it's not, or if it's real suspicious from the way it looks that they don't have the swab back, they may start antibiotics for a very brief period of time, a couple of days, until they know for sure. If we're going to give an antibiotic for group A beta hemolytic strep throat, many times it's oral. But as we can see, look at that throat. If they don't want to swallow or can't swallow, it can be given in an IM injection as well. We need to teach parents about meds. If they are getting something that is oral, again, how often do I give it, and what dosage do I give it? So how to measure that dose. If it's IM, sometimes it'll be more than one dose of IM injection. It might be up to 3 doses. So the importance of bringing them back for the additional IM injections and when they need to do that. Let's see, other symptoms, we said sore throat, headache, fever. Again, low-grade fever, if it's an older child, could be a higher fever, younger child. Abdominal pain, again, nausea, not wanting to eat, difficulty swallowing. Again, we're worried about things like dehydration, giving them small amounts of liquid. And if they aren't able to swallow, if they're refusing to drink completely, we notice they're peeing less, that's a time we need to come back or call the doctor, definitely, and talk about what could be the signs that that may be getting dehydrated. Again, dehydration doesn't mean it's group A beta hemolytic strep, but a complication definitely that we want to avoid. Okay. Another thing that with strep throat that we want to teach is to throw away their toothbrush. So they say that after 24 hours of antibiotics, they can go back to school. Again, many schools will say, yeah, 24 hours of antibiotics, but we want the fever gone too. So they can go back to school. But we also want to say is after 24 hours of antibiotics, we want to throw away the toothbrush and get a new toothbrush, because this bacteria can live in the toothbrush, and we don't want to take antibiotics, get better, and then keep spreading it to ourselves again with that bacteria that could be on surfaces. Okay. All right. Tonsillitis, okay, again, the tonsils we know play an effect in our antibody formation. And if we're thinking about young children, they have naturally larger tonsils than we do. We said they had a larger tongue. They had, in proportion to their mouth and their throat, they have larger tonsils. So what that means is with inflammation, they can become inflamed and occlude the airway much quicker than it could school age, adolescent, and adult. Okay, so tonsillitis often occurs with pharyngitis, with a sore throat. So inflammation many times causes that sore throat, as well as nasal drainage. Causative agents could be viral. Again, they could be bacterial, and how we manage that depends on, is it a virus? So a virus symptom management, is it a bacteria? We may consider giving an antibiotic for that. Again, symptoms being inflammation of the airway. With that, we think about sore throat, trouble swallowing. Many children, if we are watching and looking for definite trouble swallowing and to the point of where they don't want to swallow, we want to watch for drooling. Drooling definitely could indicate that they're not able to swallow at all, and is a very serious indication that a child who was past the toddler age especially isn't able to swallow if they're not wanting to try to talk as well. So with tonsillitis, the inflammation of the tonsils, but the adenoids are located right behind those. And if they are inflamed, they could obstruct the nasal passage as well. So kids could have kind of a stuffy nose, difficulty breathing, mouth breathing, those type of things. Let's see. So we talked about how to treat it. Again, if it's connected, many times tonsillitis with pharyngitis, we're also thinking about strep throat. So checking to see if they have that group A beta hemolytic strep and treating with an antibiotic. We want to eliminate any unwanted antibiotic administration again. So they're going to look at signs and symptoms. If there are symptoms that could be compatible with something like group A strep, then they'll swab. But otherwise, we're going to be talking about a viral infection, which is important to talk about how to manage symptoms, but also it's important to talk about, okay, we said it's viral and I'm going to manage it at home, but at what point do I know if it's serious enough to come back? And so that's an important consideration. Reoccurrent throat infections, reoccurrent tonsillitis, those type of things could lead to a tonsillectomy. The book talks about some very specific guidelines of so many infections per year and so many infections over a couple of years. And that's a great kind of guideline, but really practitioners will look at it based on the child Look at it if it's a child that is at a point where they think they may start developing more antibodies and grow out of that, or if it's a child who has repeated infections despite things like antibiotics and at it past a certain age, then they may think about removing the tonsils. I want you to look at post-op care for tonsillectomy. It talks about some things like making sure that we're monitoring for a good airway, how we check to see if they have a patent airway, monitoring for the ability to be able to swallow after anesthesia. Of course, we want to make sure that their swallowing reflex is intact, that they have a gag reflex, that we're not feeding them soon after anesthesia. And then we also want to look for signs of postnasal bleeding related to a tonsillectomy. What is a sign that we can look for in a child that could indicate bleeding in the throat?
Swallowing, excessive
Repeated
swallowing.
swallowing, right? Remember we talked about repeated swallowing. So looking in the back of the throat post-surgery, watching also for repeated swallowing, definitely. Okay. All right. Influenza. So influenza, we think about being, again, viral, a number of different types of influenza virus. So we usually think about being kind of informed by the CDC each year about what type of influenza virus, usually classified as like A, B, or C, is most prevalent at other parts of the globe. And then when it comes to fall to winter and that type of virus circulates into our environment, the influenza vaccine is based on which viruses are most prevalent. And so that really determines the makeup of the vaccine. You think about community transmissions of viruses, and that includes the flu. So more than likely they're passed by things we think about, like being around other people who are sick, by coming in contact with things respiratory wise, like having someone within our vicinity coughing and sneezing, or through contact of touching things and then touching our eyes, nose, or mouth. So touching surfaces, eating or drinking after someone, playing with toys that they've had in their mouth and our child puts in their mouth, those type of things. So again, thinking about preventing transmission by staying away from people who are sick, or if we're sick, staying away from other people, covering our cough, getting immunized against the flu, and then also teaching children when they're able to understand, probably even preschool age, cover your cough, wash your hands, and making sure that you are not touching surfaces and touching eyes and mouth, all those types of things. So what I mentioned previously was influenza is viral. But what can happen is if our symptoms aren't treated, or if we have things like thick mucus or a lot of secretions, they could progress to a secondary bacterial infection. And so we've mentioned before that one of the most serious complications of influenza is pneumonia. And that happens when we take this upper respiratory illness and either through viruses or bacteria that are in saliva, that have kind of attached to the mucous membranes, they work their way down to lower respiratory tract. A lot of secretions, not being able to cough things up, and then again, not using things like hand hygiene to prevent continual transmission to ourselves and others in our household and passing it around continuously, are things that really could stop the prevention of it going into a bacterial infection if we're cleaning things, if we're trying to avoid someone who's sick, and if we're managing signs and symptoms. So at what age is the influenza vaccine recommended?
Is it 3?
6 months.
6 months? I thought it was nasal or something.
Yes, that's a good point. So the flu vaccine, the IM injection, can be given at 6 months or greater, and it's recommended. Now, we also know that there is a lab vaccine called an attenuated vaccine, and it's a nasal spray. Now,
They can do 2 doses, right? I remember whenever my daughter turned 6 months, it was right in flu season, they actually could give her like one and then she could have another at some point.
Yes, that's a good point. So if a child is young at that 6 months age, we would give them 2 doses. So we give them one, and then, gosh, I'll have to, I want to say a month later, give them another one, but I'll have to check on that because they don't have that, that immunity and exposure to viruses. Yeah. Now at 6 months or older, we said we could give them the vaccine, but if we're giving the nasal spray or a lab vaccine, that attenuated vaccine, we have to think about, do they have the immunity to be able to take that live vaccine and use it to protect themselves, but not get sick from it? So live vaccines, such as the nasal spray, is only recommended for children 2 years and greater, okay? So they have to be able to have some form of a greater amount of a capability to be able to utilize that live vaccine and not get sick from it. We want to make sure that any live vaccine that we don't give to immunosuppressed children, and then also we're watching for children that may have had an anaphylactic reaction to egg protein. There are certain vaccines that have kind of an egg protein in them, things like MMR, those type of things. Many physicians will recommend, I think the book even recommends, that if they have an adverse reaction to eggs, so eggs make them itchy, eggs make them nauseous, to give the vaccines with some type of an antihistamine. That is really not the case with influenza. Influenza is one of those things that we think about provide short-term immunity. So if they have a serious reaction like an anaphylaxis to egg protein, that would be prohibited until many times an older age, until they build up some more type of immunity and maybe have grown out of that allergy. Okay. Let's see. Okay. So otitis media. So again, we said that when we have a viral infection like the flu, or we even have a viral infection like pharyngitis, or even a bacterial infection like pharyngitis, that those viruses and bacteria can get in our mucous membranes and kind of migrate places. So otitis media, which is or referred to as a middle ear infection, can be due to another type of viral or bacterial illness, or it can also be caused by other things that enter into the ear. For example, other types of bacteria. It could also be, you may have heard of swimmer's ear. So if water gets into the ear and it stays there, it can form bacteria in that, especially if it's lake water or creek water or things like that that already have bacteria. So a number of reasons for the cause of otitis media. So again, just because something is labeled as pharyngitis or otitis media, it doesn't necessarily mean that we're labeling it as viral or bacterial. It's a group of symptoms and we know where it's located, but then we have to investigate what is kind of the culprit that's causing it. So otitis media is simply the presence of fluid in that middle ear, and due to that, it causes irritation and inflammation. It can also cause constriction of eustachian tubes, and so due to that, children can have problems with hearing. It could cause pain in the ear, and it can also kind of back up fluid and cause dizziness or a problem with equilibrium because we don't have that balance and airflow that we do with an open eustachian tubes. So we said it could be viral, things like the flu, and then of course if it's viral, we know that we manage symptoms, or it could be bacterial. And so what they can actually do is they can take a specimen of fluid that's in the ear. Many times children have fluid that might be draining from the ear even, and they can take a specimen from that, be able to look at it and see, is it a clear fluid, is it a cloudy fluid, is it a purulent fluid, but also to test it for bacteria. And if it is bacterial, if it is bacterial, then treat it with an antibiotic. Okay, again, we're talking about that. We're taking some measures really to make sure it is bacterial. So again, we want to make sure that the child's getting better. We want to make sure we're treating a bacteria before it gets worse or it spreads to another area. But we don't want to give antibiotics that aren't necessary. Again, they can cause things like an antibiotic resistance, meaning that if I take these antibiotics and I don't need them, later when I do need them, my body's already kind of built up a resistance, and that means I have to take bigger and uglier antibiotics down the road. And it can also mean that I'm getting side effects of antibiotics. Some kids get nausea, diarrhea, all those type of things. We don't want them to have that either. So children that are younger than 6 months, they may even advise if it's bacterial to watch and wait, because what will happen is that if there is a small amount of bacterial fluid in the ear, that it can be removed, or that it will resolve itself. Okay, so even before just prescribing antibiotics, they may look at symptoms, they may manage symptoms, viral. If it doesn't get better, then they'll come back and test fluid and look and see if they need an antibiotic. Okay, so we're even making sure that it's not something that's seasonal, not something that's viral, not something that's related to something that will improve on its own. Increased risk with children that are 2 and under. They're most common at 2 and under, really because of some of the things we talked about, not only more pliable and kind of shorter trachea, but also station tubes. They're very small, they're very pliable, at increased risk of inflammation, kind of blocking those tubes. And so if we give something like an anti-inflammatory, many times we'll open it up, the fluid will go down into the ear canal, and it will resolve on its own. Increased risk with exposure to secondhand smoke. Secondhand smoke can cause inflammation and irritation. And with repeated exposure, could even cause kind of a fibrosis or a hardening of those areas so that inflammation becomes more constant. In those kind of cases, we may be looking at the need for things like ear tubes, which if they have repeated infections or repeated inflammation, that may be necessary. But again, we want to make sure that we're watching and waiting and seeing if this is something that opens up with decreased inflammation or that we need to treat with an antibiotic, and then how frequently that occurs. Important to vaccinate against certain things that can cause a middle ear infection, things like pneumococcal vaccine, things like a flu vaccine, all those things to decrease illnesses. Let's see, symptoms. So other than that, we talked about inflammation, ear pain, fever, could be cough, upper respiratory symptoms related to that inability for that fluid to kind of drain, can cause sinusitis, can cause cough. Nasal drainage many times can irritate the stomach, can cause diarrhea, can cause vomiting. So some of those other symptoms could be related to this infection in the ear that's kind of clogged off the drainage and clogged off equilibrium. All right. Okay. Another type of infection called infectious mononucleosis. What it's characterized is by an increased number of mononuclear elements. So increased number of white blood cells, particularly monocytes. And what monocytes do is they're one of the first ones that really go and attack foreign invaders. So we know that by looking at blood cells, if they have an increased number of these monocytes, then it could indicate that there is some type of infectious process going on, okay? Along with that, if we think about an infectious process, an inflammatory process, we can also have things like fever, inflammation of the pharynx, so pharyngitis. Could also be that we have exudate on the tonsils, again, looking like a pharyngitis or strep throat. But in addition to this, we have kind of a widespread inflammatory process. So with infectious mononucleosis, we can also see inflammation in the lymph nodes, inflammation in the spleen, that can affect our immune response. So we're looking at more of a systemic response related to this infectious mononucleosis. So in other types of disease processes that we may have, this may be preceded by another type of viral infection that just goes on and on. Its principal cause of it is Epstein-Barr virus, and it again infects the saliva So infectious mono is what we think of as droplet, but we also know that that it can get into the bloodstream. So it can also be passed by things like blood transfusion. Okay? It's a virus that gets in throughout our system. We can test for it. One of the most preliminative tests, and I guess probably the best test that we use, is called a monospot, and it's a blood test, and it looks for those amount of antibodies related to the number of monocytes that are in the blood. Treatment is really symptom management. People can feel sick for an extended period of time with infectious mono. One of the most common symptoms, in addition to this initial acute onset of sore throat, kind of inflammation, is fatigue. And they can feel that fatigue for weeks, even up to a couple of months. It's self-limiting, which means that treatment is based on doing what you feel like you're able to do. So conserving energy, making sure that you're staying hydrated, that you're taking medications for symptoms like inflammation and discomfort. But then also they'll look for systemic symptoms like this enlarged spleen, the splenomegaly, that has to do again with the spleen being one of the places where blood cells are formed. And if we're forming all these types of monocytes, it can cause inflammation of the spleen. Damage to the spleen can be very dangerous. So if children have infectious mono with inflammation of the spleen, one of the things that doctors will recommend is no contact sports, because we don't want to have injury to the spleen, bleeding of the spleen, which could cause to have removal of the spleen. Then that will affect the immune response of our body. Okay, so infectious mono goes beyond just respiratory. It's kind of a systemic infection. Okay. But thinking about comfort measures. So whatever signs and symptoms are, that's what we want to do to keep people comfortable. And again, they'll monitor the amount of blood cells, kind of the viral load. They'll do a couple of different T-spots to see if the symptoms are improving, to see if the number of monocytes are improving, to see if inflammation's improving. And it's most common in adolescents. Usually, they say adolescents, but usually people under age 25. Okay. And then I put a picture here too. So age 15 to 24, communicated through saliva, kissing disease, because again, it can be passed in adolescence many times from kissing, but also from things like eating after someone or coughing, sneezing, touching things on surfaces, touching nose and mouth. Again, systemic symptoms can be many times from things like inflammation that could lead to things like fever or aches or fatigue or sore throat. Pain in the right upper quadrant, again, could mean hepatomegaly, so inflammation of the liver, but also inflammation of the spleen. A fever, again, initially could be a higher fever, but then also doing some diagnostic testing. We said that the most definitive treatment is going to be that monospot to really look for monocytes and antibodies. But then they'll do liver enzymes to see how well the liver's functioning. Again, we want to make sure that medications that we're giving aren't hard on the liver. So we want to make sure that we're watching the amount of Tylenol, making sure we're using the correct age-appropriate dosage of Tylenol, as well as the formulation of Tylenol. It can be hard on things like the liver, kidneys. Looking for other types of viruses and bacteria that can be present. Looking for things like loss of appetite. We want to make sure we're eating nutrient-dense foods. Worried about quality, not quantity as much. Staying hydrated, and then resting, allowing plenty of time for rest. All right. So we talked before about group syndromes. And so what a syndrome means is a group of symptoms, okay? And they're usually occur together. So croup, we tend to say many times is referring it to as a disease. But when we think about disease processes that have croup syndromes or groups of symptoms, we're still going to describe those based on where that inflammation and where that symptoms are located. Okay, so when we talk about things like epiglottitis or laryngitis or laryngeal tracheal bronchitis, meaning 3 different places, the symptoms that go along with that are what are considered croup-like syndromes. Okay, so a child could have croup syndromes of hoarseness or this barking cough, inflammation, and it be less severe or more severe, depending on where that is occurring in the respiratory tract. Okay. So when we think about croup, when we think about inflammation, inflammation leads to pain. It also can lead to obstruction. And what we said about children is that the airway is more pliable, especially in the younger child. So when we think about croup, we usually think about it particularly in children that are 2 or younger. That can occur in children really up to about age 5, but it's notably not as serious in the older child because the airway is not as pliable, it's not as short, and because we have more of an immunity as we get older. So what we think about with these symptoms is that narrowing of the airway. Okay. And again, the larynx being kind of the voice box. I remember that with kind of laryngitis, having trouble talking, but then the trachea being the windpipe as well. Okay. So the most severe of the disease processes with croup-like syndromes is epiglottitis. And epiglottitis is always a medical emergency. It comes on quickly, and what it means is it can occlude the airway very quickly. So it is characterized by a little bit different symptoms for the older child, older meaning toddler age versus the infant. Okay, so in a child that's able to kind of sit up, we think about many times 2 to 5, we're going to see them sore throat. Many times they'll either tell us they have a sore throat or they won't want to drink anything, or if it's so sore and it's hard to swallow, we may see drooling, pain again in the throat, positioning. So if they're able to sit up, we're going to see that positioning of sitting up, of panting, of leaning over, trying to breathe, and along with that, retraction. So working very hard to get oxygen in. Those retractions being using accessory muscles, again, could be, a big abdominal breathing. The different than that in the infant is we probably aren't going to see them intentionally doing posturing or positioning. And we probably aren't going to see those abdominal breathing heavily. What we're going to see is things like nasal flaring. We're going to see not wanting to feed because they're breathing, having trouble breathing. Inspiratory stridor, again, a stridor is a high-pitched kind of a seal kind of sound, a whistling sound, and it's inspiratory because they're working really hard trying to get air in of a very, very small inflamed airway. Okay? Mild hypoxia, again, mild hypoxia being that we're probably not going to see signs of the child becoming unconscious. We're not going to see in the very, very beginning of them not being able to make eye contact, but we are going to see distress. Now, what that means is we said it progresses very quickly. Mild hypoxia we can see in the respiratory effort of breathing. We may not still be seeing symptoms of cyanosis at this point. So we don't want to teach parents particularly to wait till there's signs of cyanosis. That's a later sign that we're going to be seeing. This increased respiratory effort, not wanting to feed, irritability, restlessness, indicating distress is what we're going to be seeing initially. But in the infant, this can progress very, very quickly. Remember, stridor already means a very, very small airway that noise makes when it's trying to get through that with increased effort. So therapeutic management, thinking about how are we managing respiratory obstruction. In this, we said it's a medical emergency. So one of the things that's very important is that we're going to need to potentially manage an airway with either an artificial airway to hold the airway open, and then potentially use of, if we're not able to get an artificial airway kind of down the mouth into the trachea, could be a tracheostomy. So let's back up a minute, and we said the age groups that normally affect. So it affects children usually between infancy and about 5 years old, but usually what we think of is 2 and under, kind of being serious, more serious, because of the inability for them to really use those accessory muscles and positioning or retractions to help with that breathing. So it progresses quicker to something that is life-threatening. Many times it's caused, or the most common cause is Haemophilus influenza B, and that's prevented. That's prevented by a vaccine, that Hib B vaccine. So extremely important that we're teaching parents to get that Hib B vaccine to prevent this very serious acute epiglottitis. Examination of the throat, so using a tongue depressor to look at the throat, should only be done by someone that's in the medical setting. So we want to teach parents to monitor for the severity of respiratory by observation. They don't need to open the mouth. They don't need to look down in the throat. If they're having trouble breathing, it's an emergency. It's serious. Because what can happen if you use a tongue depressor or something to kind of look in the mouth and you stimulate the inflamed, the epiglottis, the inflamed tonsils, all those kind of things, it can promote increased inflammation, and it can lead to a situation where they are no longer able to breathe. That very small airway with stridor can swell shut and they're not able to get any air through. So unless we have emergency personnel that can intubate, that can put a trach, anything like that, we don't want to teach parents to really open up and kind of stimulate the tonsils or anything like that. With this progressive obstruction, again, we may see things that came on before this, like a viral infection. So the child can also have things like a fever. They may also have this difficulty with airway, we said. And when they have that difficulty with airway, it quickly progresses to hypoxia and then to death. So again, trouble breathing, what does it look like in a child of that age is what we need to teach parents, okay? If they come in, if it is bacterial, they have this Haemophilus influenza treatment, again, we want to treat them with the correct antibiotic. So when they come in, they get emergency treatment, they'll determine what actually is the cause for these symptoms in this area and then treat it with a causative antibiotic, or if it's not bacterial and or they may be treating them with systemic antibiotics. They could give antibiotics, again, IV. They could be given anti-inflammatories, so things like steroids. They could also be, if we're talking about a narrow airway where there's obstruction, we could be giving them some form of epinephrine to help with airway. So again, it is definitely emergent. And after we get the respiratory condition, the obstruction taken care of, then they will look at what's the causative factor and treat that. I'm sorry, go ahead.
I just wanted to, for the ones that are going into emergency room and peds, so for emergency for this, because you only have one chance to tube them because their throat will close shut. So out in the field, we give them racemic epi, which opens that airway before
that's like a nebulized epinephrine.
Right.
Yeah.
But when it happened in the hospital, in the emergency room, they didn't actually know about it. So I'm just saying, if you guys are going into them places, maybe pass that along. It really does help to intubate a child with this if you give them racemic epi first. Yes,
yes. Great point. And I think it even talks about that in the book too. That's a great point. I am going to let me finish this acute laryngeotracheal bronchitis because it still is in the croup symptoms, and then we'll take a break. So we talked about, again, that croup syndrome or group of symptoms. Again, we classify not only by the symptoms are, but where it's located, and depending on age as well determines the severity. So we can have croup syndromes or croup symptoms that are managed at home. So making sure there's a patent airway and make sure managing nasal secretions by suctioning, humidified oxygen, all those type of things. But again, if it is something where it's located in the epiglottis or even any of the places that proceed to a narrowing of airway, then becomes an emergency. So acute laryngeotracheal bronchitis, we can look at that and see, wow, that inflammation is in the larynx, the trachea, and all the way down in the bronchus. So now we're talking about inflammation that extends from the upper airway all the way down to the lower airway. And so we can think about some of those common croup syndromes being the same. So, right, shortness of breath, it could be that stridor, it could be that increased respiratory effort, and then that inflammation extends all the way down into the bronchus as well. So we're talking as well about problems maybe with some gas exchange. Organisms, again, responsible can be viruses, they could be bacteria, okay? And other things could be general symptoms like low-grade fever. It could be kind of a barking cough. And again, the sound that's coming from that is because that narrowed airway due to inflammation. Inspiratory stridor, again, that big effort to take those deep breaths through that smaller airway. Those substernal retractions, again, in a smaller child and infant, we can see the nasal flaring. Remember, that's my major work of getting oxygen in is the nose. So that nasal flaring, I'm working really hard. Also, we can see tachypnea. So parents may notice that they're having a panting, kind of increased respiratory effort. And of course, we can notice that from observation. So that may be something that parents notice as well. Want to make sure with this, we maintain airway and maintain gas exchange. So how do we measure to see if they are having good oxygenation and gas exchange?
ABGs.
Do ABGs. We could also be putting a pulse oximeter on them, right? So continual monitoring with pulse oximetry. Again, if it's a child, we can put a pulse ox on the index finger and then kind of tape it to the back of the hand. If it is an infant, we can put it on the toe, the big toe, and tape it to the bottom of the foot. And use that. But then ABGs, definitely, if we are concerned that they are having signs of problems with gas exchange, and ABG is going to be our definitive measure. So we want to, again, decrease inflammation. And one of the things that helps to decrease inflammation as well as thin secretions is humidification. So one of the things that we used to do many years ago when I started was we used to use croup tents. And so a croup tent is your big, huge crib that you have, and then would be like kind of a plastic covering that would zip around the crib. And there would be oxygen, a big oxygen tubing that was attached to the kind of the opening of the plastic. And it sent cool, humidified air in to kind of thin that secretions and decrease inflammation. There's other ways that we can do that now. Some of the things that came from that were that you had to keep a tight seal on it to keep that humidification in. And that's kind of scary for a child. So if you're thinking about a child who's 2, 3, 4, and they're inside this croup tent, they're separated from mom and dad. Either you unzip it and mom and dad can stick their arm in. We even zip parents in. When we had to give medicines or assess, we would have to unzip and crawl in the croup tent. So it wasn't a consistent way really of keeping humidified air on them, but also decreasing anxiety, decreasing crying. Crying could increase inflammation, and it could increase the work and the effort of breathing. So now we usually do a couple of other things. So we can either do kind of a mask that is for humidification. Again, that would depend on how ill the child was, whether they're able to keep the mask on. But if we have a child that is irritable, we want to keep them from crying, those type of things, they don't feel good. Many times mom and dad can hold them and they can do what's called a blow-by. And so it is kind of a large kind of tubing that cool humidified oxygen comes from, and they can hold it kind of in front of them so that the air they're breathing in is really coming from this cool humidified air. And that really can help to keep them calm as well as getting that humidified air and keep them close to the parents as well. Another thing, again, great that Erin mentioned, and I think under this part was where they talked about racemic epinephrine. But epinephrine, again, some of the side effects are that it increases heart rate, speeds up the working of the heart, and we think, why do we want to do that when we're already working on breathing? Well, it also decreases inflammation, opens things up. So in addition to epinephrine being given to kind of open things up and get their breathing and decrease inflammation, we do have to watch things like respiratory rate, heart rate, but that's going to be secondary to that epinephrine. So important that the things that we're doing, whether we're talking about epinephrine or whether we may be talking about in another case of using steroids, it's important that we're using the correct dosage and the correct administration. And so many times these things are used very short term because of those kind of side effects of increased heart rate, respiratory rate, and they are used when it's emergent or very, very serious, so to open things back up. So again, with this, stabilize them, get them breathing, making sure that we are treating symptoms. We also want to know what's causing it. Again, we know that it's inflammation in the larynx, trachea, and bronchus, or bronchial, but what's causing it? And so again, then determining, is it respiratory, is it bacterial? If it's bacterial, many times they will get either a sputum specimen, or they may have to, if the child's very ill, even go down in the bronchus with a bronchoscopy, maybe, and remove whether it's mucus or whatever and test that. But treat it if it's bacterial, treat it. If it's viral, they want to treat that. And then again, important, even at this point, is talk about vaccines, whether we're talking about vaccines for the flu, whether we're talking about the pneumococcal vaccines, whether we're talking about infection prevention. So again, not spreading it, avoiding viruses, hand washing, staying away from people that are sick, covering cough, all those kind of things. Okay. Symptoms here we have, okay, we talked about. Again, frequent upper respiratory infections many times precede it going to the inflammation and down into the bronchus. Important why we want to teach parents that if they're treated for an upper respiratory infection and it doesn't seem to be getting better, or they develop a fever that is increasing, bring them back. It could indicate something either deeper in the respiratory tract, or something that could be going from into a secondary bacterial infection. Okay. We said again, symptoms that could indicate problems with respiratory tract, problems with getting oxygen in, getting CO2 out, again, affecting gas exchange. Airway management, again, could be from positioning. Again, even after we have made sure that they have a clear airway, either they have giving them epinephrine, or we've got there in time and we have made sure that they are getting hydration and oxygen. Even thinking about airway management being keeping the head of the bed of the crib up, or keeping them sitting up in mom's arms or something like that. Those positioning are also very important to keeping airway open. And then nebulizer treatments. Nebulizer, I'm sure many of you have seen the nebulizer treatments in the hospital. So instead of it being medication that is given IM or even oral or even nasal, a lot of medications like epinephrine, steroids can be put in a liquid form in drops into a container that's mixed with oxygen or mixed with humidified air, and they can breathe it in. And it doesn't even have to be what we think about with a neb treatment of putting our mouth on it and instinctively breathing it in for the young child. It can be even holding it in front of them so that they're breathing it in. Lower airway, again, considered reactive. So what we mean by that is, let's see, we get to, all right, let me stop here because I think we're starting to talk about things that are distinctive with a lower airway. So let's go ahead and take a 10-minute break and we'll be back. Okay.
Mrs. Lowe,
Yes.
I have a few questions.
Okay.
My first one is, with the strep culture, when you get a strep culture, isn't it true that it will show up positive if you're a carrier and if you're infected? So how do you differentiate between if that caused it?
That's a good point. So looking at symptoms. So it's kind of twofold, looking at symptoms and then looking at the culture. Usually if you have a positive culture and you're a carrier, you don't have symptoms.
Okay. And my second question was, did you say if you give children fluids with sugar or caffeine, it causes diarrhea?
It can. Mm-hmm.
Okay. Is that just from the pulling the water out, like with the sugar?
Yes.
stuff?
Yeah. Mhm.
Okay.
Mhm. The lower airway, we consider it a reactive portion of the lower respiratory tract. So what that means is traditionally what we're thinking about in the upper airway is inflammation on the inside and obstruction due to inflammation or things like mucus. The lower airway is considered reactive. And so what that means is we can get inflammation on the inside, but also squeezing on the outside of the different portions. And that means we're talking about the bronchi and the bronchioles. And so the bronchi being the larger branches that come off the trachea, and the bronchioles being even smaller that come off of that. So we know that the smaller that the airways go, the further that they go, the smaller they are. And also the bronchioles are connected to the alveoli. And so we're getting really close to gas exchange there. It says the cartilaginous support is not fully developed until adolescence. So again, thinking about all of these airways being very, not only small, but pliable, which means that they're soft. And if there's inflammation on the outside, then that squeezing can collapse them. And so the airway can be obstructed. And then constriction of the airways, again, any part of the lower airways is going to affect gas exchange. Excuse me. Okay, so we're going to talk about a couple of disorders. Now, when we think about, let me back up a minute. When we think about lower airway, we think about a couple of disorders. So things like bronchitis is pretty common. Bronchiolitis, which is again, bronchitis means kind of the larger airways coming off the trachea, and bronchiolitis is the bronchioles, the even smaller ones coming off. Pneumonia, TB, a lot of things that could be lower airway. And again, could be caused by bacteria, especially in things like TB bacteria. But like other things like pneumonia could be bacterial or viral. So again, thinking about the disorder, the symptoms and where it's located, but we still may need to determine what the causative factor is. So bronchiolitis is an acute respiratory infection and it's viral. Most common cause is RSV, which is respiratory syncytial virus. And it causes lower respiratory symptoms. But also it can have upper respiratory symptoms. So when we think about that, we think about inflammation of the lower airway and cough, but many times with a virus, we still get kind of general viral symptoms, which could be runny nose, cough, sore throat, all those types of things that we traditionally think of upper respiratory as well, okay? But the primary location is going to be lower airway, affecting those things like gas exchange. The primary happens in kind of cold and flu season, so winter, early spring. Children can be hospitalized many times if they're under a year old from the things that we said. The smaller airway, they're more pliable, they can't clear secretions like older children can. So very young children can be hospitalized for RSV, and we see quite a few children hospitalized, particularly very young children. Probably one of the sickest I've ever been in my entire life was I worked in an ICU and I was taking care of a baby that had RSV. And you know, when you're taking care of an older child or an adult, then you kind of have a distance from them. But when you're taking care of an infant, you're holding them. And I remember that infant coughed right in my face. And I thought, that's it, I know it, I'm gonna get sick. And I was so sick. So RSV is common in children, but older adults, I mean, the older children and adults can get sick with it too. They usually don't get as sick. We said that severe RSV also increases the risk of other types of things. So severe RSV we see in younger children that can be hospitalized, but children that have severe RSV or repeated bouts of RSV have an increased incidence of developing asthma later in life. And so what we're looking for really is the very young child that has breathing complications, hospitalization, or if they have complications related to secondary bacterial infection down in the lungs that won't resolve, they need IV antibiotics, those kind of things, then they may be admitted to the hospital. But usually children are at home that are older than a year old with RSV, and it can be managed at home. What we think about to keep them healthy and at home is maintaining an airway, okay? So making sure that we're keeping the nose clean or keeping it clear from secretions. If they aren't able to sit up, if they're an infant, we keep the head of the crib up or keep them in an upright position. We're monitoring for problems with breathing, with the nasal retractions, those type of things. We're watching intake and output. So is it an infant that isn't wanting to feed much, but we're also watching wet diapers, having less wet diapers. One thing that you may notice in an infant too is that they just are a little more lethargic. They're not crying as much. You know, we expect an infant to cry when they're wet or to cry when they're hungry or those kind of things. And if you have an infant that just seems like they're not as irritable as they were, that's a serious sign. So that could be problems again with gas exchange. It could be dehydration and something that we would need to be seen about. Thinking about keeping older kids hydrated. So again, if they can take oral fluids, if they are able to breastfeed, bottle feed, continue that. Sometimes breastfeeding, it takes an increased effort. So if they're not able, but mom's still breastfeeding, she could pump and then give that to them in a bottle. Pedialyte, Infolite, all those types of things. They may be prescribed some other medications at home in addition to things for fever. They may be prescribed a bronchodilator, whether that may be in an inhaler, whether that may be in a nebulizer. You can have home nebulizer machines that can either nebulize a steroid to help bronchodilate. We can test for RSV. So there's a rapid, again, antigen test for RSV and its nasal secretions, and they can test for that virus. Again, it's viral, so we really don't give antibiotics or anything like that for a viral infection, but we know with this RSV, it's very transmittable. So we want to make sure that instead of it just being something like the common cold, that we identify when it's RSV and we realize that it can progress to more serious complications. And we're watching airway, and they're also preventing transmission. So if we had a child that came in with RSV, then they would be in droplet precautions. Okay. Other types of things they would do in addition to that antigen would be to see, since it is lower airway, anything that's lower airway, we're worried about inflammation in the airway. So they may do a chest x-ray, and what they would see with RSV is going to be like a hyperinflation of the lungs, inflammation of the lungs. And again, we'd be concerned about airway, oxygenation, and then also hydration. Okay. Pneumonia, again, pneumonia is kind of an umbrella of the lower respiratory disorder, infection, and caused by a number of things. So it could be caused by viruses, bacteria, mycoplasma. Mycoplasm is kind of like TB. And aspiration of foreign substances. We know we can aspirate secretions, food, foreign objects that go in the nose or go in the mouth or any of those things, and they can get down into the lungs, either cause an obstruction or cause inflammation and infection to grow around that. So we'll talk about kind of like aspiration a little bit different, separately. But pneumonia, in general, thinking about it, is an inflammatory process of the pulmonary tissue of the lungs. So the lining of the lungs, it's inflamed. And what that means, of course, is that we can have discomfort. Okay? We can have discomfort of trying to take good breaths. So what do? We tend to take shallow breaths. And with shallow breaths, we can see that we're taking more frequent breaths, so kind of a panting. We can also see some changes in oxygenation, so changes in gas exchange. Other things that we would note would be that, again, some lethargy in the child. So just not wanting to play, not feeling good, not wanting to really interact. We could see a fever. We can see a cough. Again, it could be productive or non-productive. And then again, watching especially for those signs of problems with oxygenation that we talked about. So pneumonia, like we said, can be a primary infection or secondary infection. So what I mean by that is primary means that I have been exposed to something, it got down in my lungs, and I have an infection. Secondary is what we think of, like we talked about, the flu. So if I had a flu, it was kind of upper respiratory. I had a lot of secretions that went down, inflammation, got down into the lungs, kind of blocked some of the airways, and the bacteria or proliferated or spread down in my lungs, or the virus was in the bacteria and it trapped in there, and bacteria started to form in there. And even with bacteria, we can think about white blood cells, old white blood cells, all those kind of things. So that could lead to an infection in the lower respiratory tract, and that's what we consider a secondary infection. And of course, that many times would it may affect how it's treated. Again, down in the lungs, if they determine that there's bacteria, then of course they would treat it with an antibiotic. Viral, they would not. But a lot of times what it really means too is we're asking parents about if they were sick recently. So sometimes it could be like somebody who had the flu and then they seem like they got a little bit better, and then they started to get worse again. And so we would see that they had that flu, and then they started to get better, and then either there was inflammation and they were breathing shallow, or a lot of secretions, those kind of things, and then pneumonia resulted from it. And so that it could be listed differently, either primary or secondary. Some types of bacteria that could result in pneumonia are things like group B strep. We talked about some of the strep. Again, it could be viruses like RSV or pneumonia, or any really common respiratory viruses. To get pneumonia, like we said, it can either be inhaled, so inhaling some of those things, and traditionally when I think about inhaled, I think about TB, like mycoplasms, or it could be things that are bacteria that have come from secretions in other areas. So viral treatment we know is symptomatic, okay, but that doesn't mean that we're not monitoring for the same kind of signs and symptoms. We're still worried about oxygenation. We're still worried about a patent airway. We're still worried about taking big deep breaths and inflammation, taking things to decrease inflammation, taking meds to decrease fever. It may be using moist humidification to open airways. All the treatment of symptoms may be the same, except the antibiotic. What they would do to determine if it was bacterial, since down in our lungs, is if someone coughs up mucus, they could test it. But if it's down in the lungs, sometimes what they'll do if the child is really symptomatic is that they will do a bronchoscopy and kind of go down there and get a specimen and test it and treat it. If they can't do that many times, they will treat with the most common type of antibiotic for lung infections and watch for improvement. Okay, so we have to think about kind of, if we don't have sputum, is it worth, sedating them and kind of the trauma and everything, going down and doing a bronchoscopy, which if it was a pneumonia that was not resolving or repeated, then they would definitely do that. But other than that, they probably would do a chest x-ray to look at inflammation, manage symptoms, steroids, decrease inflammation, oxygen, and then treat them with the most common antibiotics to relieve pneumonia, bacterial pneumonia.
I have a question about the bronchoscopy. When they do those and they do bronch lavages, how exactly does that work? Because when I think about putting liquid in the lungs, I'm like, well, you're drowning them.
It actually is kind of liquid and suctioning at the same time. So any place we really do a lavage, even if you think about the peritoneum, it is fluid in there to flush it out. And many times if they're doing a bronchial lavage, there's a lot of thick mucus. And so they actually are kind of thinning everything out, but suctioning at the same time.
Okay, so they don't let it sit in there. It just kind of
No.
in and out, in and out.
Yeah.
Okay.
Yeah. Mhm, mhm. So signs and symptoms of pneumonia, again, it's going to depend on the age. And we talked about why younger are at risk, and also being able to have a child that you can, that can cough and cough things up when we want them to, and being able to take breaths. Being able to take certain medications like steroids or medications like decongestants to help to kind of dry things up, or take medications like that can break up secretions, all those kind of things we think about that may not be safe for the very young child, can be given in the older child. What's the cause? So how are we treating it? Is it going to be bacterial or viral? Again, determining, again, treating symptoms the same way. But if it's bacterial, we'd be using an antibiotic. A systemic reaction to infection. Again, what happens as well is if we have an infection that's lower respiratory, we also have an increased risk of that bacteria getting into the bloodstream. Excuse me. And so they can actually as well check for things like increased white blood cells. We can check for, depending on what the causative factor is, sometimes we can check for antibodies, but knowing some of those systemic symptoms aren't restricted to lower respiratory. So we said that they may have a fever, they may have nasal secretions, they may have a sore throat, all those things that could be in other places like upper respiratory, but really the etiology or the kind of epicenter, if you will, is lower respiratory. Okay, and we said those symptoms can kind of go different places. The extent of the lesion. So kind of what we mean by that is that with a lot of types of particularly bacteria or even viral illnesses that can get into the bloodstream, they may also have a skin reaction, especially in children. And so many times if kids get a virus, or if they get even a bacterial illness or something like that, in addition to feeling really bad and kind of coughing and all those kind of things, we see a skin reaction. And that's our body's way of really kind of trying to hone our inflammatory process, our autoimmune process. And so it kind of goes into overdrive when we're younger, because we're just starting to be able to go and kind of fight things. So with this, we may see little pinpoint rashes. We may see rashes that are itchy. So one thing that they may do is if a child comes in with even like a respiratory reaction, is they're going to want to examine them and look for rashes. A lot of times it'll start on the trunk, kind of central, and then it'll move outward. But even after a viral infection, many times after the symptoms respiratory have kind of resolved, this skin reaction will kind of be what's left over of our body still trying to fight, and we'll have kind of a skin reaction. So we want to monitor that. We want to monitor and make sure that there's no signs of bacterial infection on the skin. So we know scratching and itching and all those kind of things can lead to skin infection. Things that they recommend as well, I think we talked about, is using things like a warm or a cool bath or cool compresses. As well as at a certain age, they may be able to use something like a Benadryl cream or some other type of cream on a rash to decrease itching, keeping fingernails cut short, but then also monitoring those rashes again to make sure that they are resolving as well as the respiratory illness, so that we're not getting any type of bacteria from underneath the fingernails kind of scratching it, those kind of things. When we talk about other types of lesions, we can know that respiratory illnesses like TB, many times when they are advanced, can lead to kind of sores on the skin and those kind of things. So again, any type of kind of respiratory reaction can have symptoms that relate to the skin. So we want to assess that as well. And then also looking at degree of obstruction. Again, knowing that inflammation in the lining of the lungs along with that inflammation, we said can obstruct airways and also can lead to things like increased secretions. So making sure that not only do they have an airway where they're getting in air, but we also may need to assess for gas exchange as well. So looking for things when they've come in, not only for O2 sat, but also looking at ABGs, like we said, looking for overt signs of confusion, as well as trouble breathing, all those kind of signs that we're looking for. I don't think I had any other. Let's see if I had any other notes I was going to tell you about, but I don't think so. Pertussis, or whooping cough, is caused by Bordetella pertussis, and we do have a vaccine for that, and it's our DTAP, or diphtheria, tetanus, and pertussis. And so from a very young age, we start getting those. We get 3 of those vaccines. But then later in life, starting at about age 10, really are looking at kind of the middle school kind of the vaccines. I think you can start even at age 10. We get the Tdap. And so what that is the booster. They started realizing that even children that were getting the DTAP, we were still having incidents of whooping cough. And so they were wondering about the length of immunity and how long we have antibodies. So they started recommending a Tdap, and that is the booster shot to prevent tetanus, diphtheria, and pertussis, or whooping cough. We still see cases of whooping cough, and it can happen just because we're talking about it in peds. It can happen with adults as well. And again, it's a lower respiratory illness. So we have signs of cough, very deep cough, and it can result in pneumonia as well. So anything we're having inflammation, again, it can trap fluids and bacteria, and that bacteria can spread and cause pneumonia with inflammation of the tissues. Other things that we can see with whooping cough are a very severe cough. Many times it's a non-productive cough, but it can be so severe that it causes things like rib fractures. Patients get dizzy and have syncope because, again, with the inflammation, it can affect gas exchange. So thinking about with managing symptoms, being that patients are staying hydrated, they are getting frequent rest periods, and then looking again at what at treating the bacteria. So Bordetella pertussis is a bacteria, so we would treat that with an antibiotic. And again, they can test nasal secretions to be able to see if it actually is this bacteria. So our patient would be in droplet precautions, but not everybody with whooping cough, again, comes in the hospital and is in droplet precautions. So if we're seeing them on an outpatient basis, we would need to definitely make sure they understand it's incredibly contagious, especially in very young children, again, for the number of reasons that we've said. So we want to make sure that they are staying home and they are being treated, and making sure, again, that we're stressing those vaccinations to prevent the whooping cough. When we traditionally see it in older people, many times it's because they haven't got that booster shot. So making sure, again, with our older population, kind of off subject, but that we're assessing for vaccines in our older population as well. If it's not treated and the inflammation persists, then seizures can happen, death can happen from it. Patients can present with apnea. So again, monitoring and making sure that we're recommending vaccinations, and that when patients are coming in with low respiratory infections, again, it could be a number of things, and they can progress very, very quickly the younger that they are. So we talked about a number of ways that pneumonia can happen, and one of them is an aspiration, which is where either things that we're trying to swallow go down our airway, go down our trachea, and go down into our lungs, or it can happen in other ways as well. So think about our patient that's not able to swallow or having trouble swallowing, and we think about that with patients that maybe have had some type of paralysis or have had anesthesia. Trying to feed someone who is lying down on their back can cause aspiration. Also, feeding a child that's crying many times, that can cause them to kind of gasp and aspirate. And then again, thinking about that aspiration isn't just in the mouth and down in the lungs. So we think about foreign body aspiration. Think about our 1 to 3 year olds, and particularly 1 and 2, they're very adventurous, and they want to put everything in their mouth, but they'll also stick it up their nose and Going back to otitis media, they can stick things in their ears too. So teaching parents from the very beginning about keeping things away from infants and toddlers that they can put in their mouth and nose is important, because many times we don't realize that they've actually done that until they have taken a big deep breath back and it's gone down in their trachea and down into their lungs. So it can either get into their lungs and cause an infection like pneumonia, or it can obstruct the airway. So even talking about types of foods, we talked about hot dogs and grapes and those kind of things that are small and round, that are about the size of the trachea, that can actually obstruct the airway, making sure if they're feeding them, those kind of foods are cut very, very tiny. But then also age-appropriate toys. We know that there are toys that have little batteries or Legos or Barbie shoes or all kinds of things that they're not appropriate, age appropriate for 1 and 2. So sometimes parents tend to think that the age recommendation on toys is just because they won't like playing with it, but it's actually for safety. And that's easy to say when we only have that child, but if we have multiple children in the home and they have toys with small pieces, we have to really make sure that they're kept out of reach and out of the way of very small children, and so that they're not putting them in their mouth, their nose, and aspirating on those things. So traditionally, when we think about an aspiration, we think about either obstructing an airway and kind of gagging or choking or wheezing or even coughing. And it depends on the level of the obstruction. Of course, if they are obstructing their airway completely, they're not able to get air in, they may be coughing, having trouble breathing. But if it's a small piece that is small enough to go all the way down into the bronchioles, then it's going to sit there a little while. And what we're going to notice is that over time, they're going to develop an infection. And then when we do a chest x-ray, we can see that little piece down there that has grown bacteria or vegetation or something on that now needs to be removed by bronchoscopy because it's going all the way down into the airways. So again, chest x-ray to kind of look at it, they may have to do a bronchoscopy to get down in there. If it's a little piece that's stuck up in the nose, the fear is that they could again suck that back in and it could go down into the airway. If it's caught in the nose, they can do a little suction and kind of pull that out. But then again, thinking that it depends on the age of the child. Again, if they're old enough, maybe a preschooler to teach them to blow their nose or something like that, that would work. But younger than that, it really is kind of emergent, that even if something's stuck in their nose, that it is a pathway to go down into the lungs. Okay? Educating parents about the risk of aspiration. Okay? Also, we said when we have patients that particularly are not able to turn in bed, that we lie them on their side or the head of their bed elevated, that we're not trying to feed before, after anesthesia, before gag reflex comes back, before they're able to swallow. And discourage parents against force feeding. So if kids are not feeling well and they're crying and they're trying to make them eat, they don't have to eat. Hydration is the most important. And so kind of encouraging small amounts of fluid over time, but they don't really have to eat. And then also remembering that if we suspect a foreign body aspiration, we don't ever want to do a blind sweep in the mouth. So we don't ever want to just stick our finger in and sweep around, because we could actually push that obstruction further. We want to make, and they could choke on that. So we want to make sure that if we do suspect there's something in their mouth they could be choking on, that we actually can look in their mouth. If it's in their mouth and we can get to it, we can get it. But other than that, we want to turn them over and do kind of a swift kind of pounding on their back or patting on their back to get them to cough. Okay. All right. So from aspiration pneumonia can result. Okay? It occurs when anything, food, secretions, foreign materials, like we talked about, anything they could put in their mouth, enters their trachea, goes down into their lungs. And from that, our immune response causes inflammation, causes white blood cells to go to the area, and can also wall it off, and bacteria can start to form around it. And due to that, they can start to have pain, they can start to have trouble breathing and taking deep breaths. And so that would kind of bring them in to the doctor's office, and then they would kind of take a chest x-ray, look for anything that could be inflammation or fluid or a foreign body, and they could see that on there. Okay? And then we know that when it's gone down to the lungs, then they have to do a bronchoscopy, put them to sleep, and take a scope and go down there and get that. We also worry about with inflammation, then scar tissue could develop, and so it could damage part of the bronchiole. Again, making sure that we're preventing aspiration, keeping patients NPO that need to be NPO, watching for signs that they aren't able to swallow. So we talked about the child who was having trouble breathing and was drooling. And so again, that would be a sign that they may be having trouble swallowing due to inflammation, due from irritation, those type of things. Making sure that not trying to force kind of a child to eat or bottle or something like that when they're crying. I've seen parents try to put the bottle in the kid's mouth and then squeeze it to try to get milk to go in, and we don't want to do that. So we want to encourage them to use kind of a sucking reflex on a bottle, and if they're not able to do that, then we may have to think about another way to give them feeding, but we don't ever want to kind of squirt things in their mouth. In addition to that, if we're giving medications that are liquid, we want to point it toward the outside of the, or put it in the mouth and point it toward the outer cheek so that it drains down the back of the throat. Never give medicine and kind of squeeze it to the back of the throat. And again, that's an important thing that we need to teach parents too. So also making sure that, again, if someone's not able to swallow, or that we have a child maybe that's even nauseous and vomiting and those kind of things, we lie them on their side. Encourage parents to lie them on their side. Okay. So
Question with the oily drops. Is there, I don't know, with studies, any increased risk of aspiration pneumonia with like adolescents who vape? Because that stuff's in oil.
I would think so, yeah. Yeah, I think that's actually what it kind of contributes to, is some of that oil that resides down in the lungs, and it creates that kind of inflammatory process. I'm glad you mentioned that. One of the things that we recommend with young children who have nasal stuffiness, we don't want to use traditional kind of certain kinds of adult nasal drops and things like that. What we recommend is using a saline spray to kind of loosen secretions, and that can help with suctioning, like a bulb suction, those kind of things. But we don't want to use anything that has more medication or more substances that can be oily or things like that that could actually go down and settle in the lungs. Especially when we talk about young children, they don't have the cough reflex to, if something's irritating, to kind of get it back up. So asthma, we know it's chronic inflammatory disorder of the airways. And so we think about lower airways again. We think about the bronchus and the bronchioles leading to the alveoli, and it's recurrent. So we think about someone as having asthma that's a chronic condition, but the episodes of having an exacerbation or episodic. So it's not consistent. It will be irritated or exacerbated at different times. And so one of the things we said before is, with asthma, we have to figure out what causes those irritations. And then there's a number of ways of doing that. So we'll talk about that. And then also assessing for the severity of symptoms. So many times we know that, I think of asthma kind of like a complex disease process, like I would think about diabetes or something like that. And we know there's a lot of teaching that goes involved. With asthma, it is too. So it could be caused from things like, again, pollution in a certain area. It could be caused from allergies. It can be caused from inflammatory response of exercise. It could be caused from eating certain types of foods, going out into cold air, a number of different things. So we have to really monitor what is causing these exacerbations. And in children, that's hard to do. We can't get their input from it as well. And if it's just starting, we don't have a history of seeing what could be causing these things. So our primary consideration with children is really decreasing inflammation and making sure we have opening of the airways. But these episodes, we can see wheezing. And so audible wheezing, we should be able to hear that, but you can also hear it with a stethoscope, either inspiratory or expiratory, and that wheezing equates to inflammation. So the lower airways, when they become inflamed, the space for air to travel gets narrower. And so when that air is moving through narrower pathways, that wheezing occurs. Breathlessness, again, having trouble catching their breath. It could be either at rest, or it could be with exertion. So sometimes if kids are active and they're doing sports and those kind of things, then they can get really breathless, and that can trigger inflammation. But other times, if it's something that triggers it, like the weather, like cold weather, or getting a virus and getting inflammation from a virus, or even things that you eat, it could be at rest that they get breathless. So when you get breathless, kind of can indicate the severity as well. We know if somebody gets breathless when they're up moving around and active, try to sit down and calm down and see if that decreases inflammation. They could have a cough, especially at night. Many times it's because we're lying down and secretions can go down into the lungs. Also, when we're lying down too, our respiratory effort is slower. And so with that, it causes coughing and more inflammation of the airway. Another reason, as well as kind of nasal drainage, is sometimes babies and even older children too, but particularly note in babies, they can have gastroesophageal reflux, and where they're spitting up and things like that. And if they are having that reflux and they're lying flat in bed, it can actually reflux, and some of it can aspirate into the lungs and cause inflammation. So sometimes if they diagnose GERD and they're treating the infant for GERD, they may recommend treating with medication, but also keeping the head of their bed up, and that could decrease that irritation due to GERD. Limited airflow and obstruction that reverses spontaneously or with treatment. Again, it happens in kind of comes on quickly, and it happens repeatedly at different intervals. Limited airflow, of course, meaning the movement, and obstruction meaning narrowing the pathway. It also says bronchial hyporesponsiveness. So what that means is that hyperresponsiveness means there's inflammation inside of the airway, but also our immune response to that is the muscles on the outside of the airway start to squeeze in. So we can have kind of this double whammy of it's not only getting irritated and inflamed on the inside, but our immune response can kind of speed up the amount of white blood cells, all those kind of things. It can actually cause swelling on the outside of the airway. So many times it can be treated in a couple of different ways. This is kind of that picture what I was talking about. It's airway obstruction, and then is in B, and a normal lung is an A. So we see that due to inflammation, it says degradation of mast cells, which causes that kind of squeezing on the outside, that smooth muscle contraction, but also inflammation on the inside, and the normal mucus we have moving around in there gets trapped. And so that mucus that gets trapped can form bacteria, or it can form an area that's more difficult to get air through. Okay? It says hyperinflation of the alveoli. As we're working hard to take those big deep breaths and working hard for gas exchange, it can cause problems with kind of edema of the alveoli, and we think, well, that's a good thing, we want more alveoli. But what happens is that it actually, as it is edematous, it actually takes the grooves out of the alveoli, so there's less surface area on all the alveoli. So let's think, I usually think about it as kind of a bunch of grapes, and there's a whole lot of surface area, but with inflammation, it's just one big grape. So we don't have as many kind of grooves and nooks and crannies to be able to work it with gas exchange when there is inflammation in the alveoli. There's a severity classification in the book, and I'm not going to ask you to memorize the severity classification, but what I want you to understand is that based on the severity of the child's symptoms and how often these symptoms persist, the physician, the ear, nose, and throat doctor, the allergist is going to classify their symptoms. And this classification really determines the treatment that the child will be on. So if we have the intermittent asthma or mild, may not be on any medication, or what they may have is a short-acting bronchodilator, like a little albuterol inhaler that they carry with them. So maybe if I'm going to do sports, that I use a puff before I go out and play football. If it's moderate persistent, then that means that I'm probably on something that's a long-acting bronchodilator or long-acting bronchoagonist. So in addition to my little albuterol that I carry for an emergency that acts quickly, I may also be on something like a steroid bronchodilator mix, like a Spiriva or a Brio or something that I use every day, regardless of symptoms. Even if I'm not having symptoms, it helps to keep the symptoms away. So it's important we can see with that education of knowing, what do I take when I just have symptoms because it works fast, and what do I take every single day to keep symptoms away? Because if I use that long-acting bronchoagonist that I take every day for immediate symptoms, it doesn't work like that. It decreases inflammation slowly, and it keeps inflammation away. So if I get them confused, then I'm going to have problems with the asthma exacerbation. Severe persistent asthma means that my treatment plan is not managing my asthma. So severe persistent asthma means that I'm continuing to have these exacerbations, and they're really bad. That could be someone that is in an atmosphere or an environment that they can't get away from what's causing it. So again, very polluted, secondhand smoke in the home. It could be from allergens that they're in their environment. Again, it could be maybe something for this would be sending them to an allergist to get allergy testing and allergy shots to decrease their response to allergens. It could be someone who, in addition to taking medication, is also taking medication by nebulizer when they start to get bad. It could be someone at certain times of the year, their symptoms start to get out of more prevalent, but severe usually indicates that they have a severe reaction that could almost be anaphylaxis. And we think about that as someone who is not well controlled. Probably not through any fault of their own. It doesn't necessarily mean they're compliant, but it means that this is a very child who has a very severe allergic reaction, or a child who has multiple allergens, or someone who, like we said, the medications aren't working for them. Could be someone who can't afford medication or doesn't understand how to take the medicine. So a lot of factors that go into that. So drug therapy, I kind of mentioned talking about this, and we know that it can be long-term medicine preventative, I take every day no matter what, or quick relief medication, that's rescue medicine. Now, just because someone's on long-acting doesn't mean that they don't also have medication for a rescue. So they could come into contact with something and need it. They could get a respiratory virus and need it, okay? A meter dose inhaler is just something that is describing how it's administered. So just because we are using bronchodilators or steroids doesn't mean that we're using it in an inhaler. It could be used in a nebulizer machine. Other types of long-term medications could be even tablets. So you could take a Singulair, which decreases kind of your immune response to it. That's a pill. But a meter dose inhaler, the reason I put that on there is because there's a lot of teaching that goes along with it. Again, if we're giving someone an inhaler for the first time, they need to know how to use it. If it is a child, particularly younger than school age, they're probably not going to understand how to squeeze it and then take a deep breath and hold it. And so we can use a spacer. I think I put a picture of that in here. I know there's one in the book. But a spacer simply is a space that holds the medicine until I'm ready to breathe it in. Now, I can't set it there for an hour, but what it does is that the inhaler can be pressed. Let's say I'm not even strong enough to press it with one hand. I can press it with two. The medicine goes kind of out in this little chamber, this air chamber, it floats around, and then I can put my mouth on it and breathe it in. And it's useful if we have a child that maybe is even school age that tries to do it on their own, or even with a parent, because they don't have to tell them, as soon as I squeeze it, you need to breathe in. It can kind of be two different steps. Corticosteroids, there's some steroid that's in some of these long-acting bronchodilators, but then also corticosteroids can be used in kind of a little bit bigger dose if we have severe inflammation. If it's affecting our airway, if we've tried the other things that haven't worked, they may give someone like a Medrol dose pack, or even an injection of steroids to decrease that respiratory inflammation. And then cromulin sodium, that's a nasal spray. So there's different types of nasal sprays. There's nasal sprays for allergies, and then there's some to decrease inflammation. And this cromulin sodium is in a lot of nasal sprays to decrease inflammation, even some over the counter. And they can, one of the things with them is they can become a little, I don't want to say addicting, but I say you can get a rebound effect. So if you use those nasal sprays often, even according to direction, once a day, twice a day, whatever it says, if you all of a sudden stop taking them, you can get a little bit of rebound inflammation in your nose, some stuffiness that may take a couple of days to kind of wean yourself off of and get rid of. I'll finish this one, then we'll go take a break. Again, another just description of medication. Albuterol, short-acting bronchodilator, long-acting bronchodilators, again, used daily, numerous different kinds. Many of the long-acting bronchodilators, if you look at the ingredients, there are multiple ingredients. So things like Brio have 2 ingredients, I can't remember the name of it. It's another one that has like 3 different ingredients. A lot of times it's a long-acting bronchodilator. It's a form of a steroid. And then sometimes it can have a third kind of something, maybe another type of bronchodilator in there. It's different for different types of medications, but in one kind of medicine. Theophylline, we talked about that many moons ago when we were talking about medications, and theophylline, aminophylline, those kind of medications. They used to be used a lot for asthma exacerbations because we didn't really concentrate so much in preventing asthma. We just treated it after it happened. And so after it happened, it was very severe. And they would give theophylline either in an IV, respiratory, rectal suppository, and it would bronchodilate. But theophylline is one of those medicines that has a very narrow therapeutic window. So it says monitor serum levels. You have to monitor blood levels with it. And so it's not used as often as these other ones unless it's a severe exacerbation. I'll still see it used, IV, some of those things in hospitals, but we want to prevent it from getting to that point now by using these other types of medicines. Leukotriene modifiers, those are things like Singulair. And so taking the pill, it can work for asthma, allergies, some of those types of things. And it actually decreases that white blood cell kind of over response that some people with asthma have that causes problems with the narrowing of the airway. Okay, questions? All right, okay. Let's go ahead and take our 10-minute break and we will be back and we'll finish our lecture, okay?
You're muted, Miss Love.
Thank you, Erin. Can you see my PowerPoint okay?
Yes.
Okay, all right. So some of the interventions, again, it's going to be based on what the etiology is. So we definitely want to manage symptoms of asthma exacerbation at the current time. So trouble breathing, inflammation, but we also want to prevent further exacerbations. So with exercise, it says evaluate for exercise-induced bronchospasms. And what that means is that we need to have a discussion with them about when are these exacerbations occurring. And again, exercise-induced bronchospasms, we would treat preventatively right before they exercise even. So if they're only having a mild exacerbation when they exercise, it may be using a couple of puffs of an albuterol short-acting bronchodilator. If they are having more moderate or severe when they exercise, then they may be put on something daily plus a short-acting bronchodilator. But many times, like we said, it's not always just one thing. It could be multifactorial. So does exercise play a part in it? Chest physical therapy. We don't traditionally think of kind of a chest physical therapy for particularly asthma exacerbation. That may make inflammation worse. But what we do think of is other kind of disease processes that have asthma-like symptoms. So we're going to talk about cystic fibrosis, and particularly with cystic fibrosis, there is a lot of thick kind of mucus that can cause narrowed airways, and they may have asthma-like symptoms, trouble breathing. If mucus or thickened secretions are the problem that lead to these asthma-like symptoms, then they may actually use this chest physical therapy, and it can be done a couple different ways. It could be where a physical therapist actually kind of cups and kind of on their back, kind of does a little pounding on their back, and it helps break up secretions. But other ways are kind of, especially for patients who have chronic conditions like cystic fibrosis, they can have vibrating vests that they put on. And so it's the vest that actually does the vibrating a couple of times a day. And it helps kind of break up secretions, loosen secretions so they can cough them up. Okay. Breathing exercises. So if we want to keep our lungs expanded and our alveoli expanded, we usually teach people to cough and deep breathe, right? To using a SIM spirometer. But what do we do with a child if we can't really, teach them to use a SIM spirometer or the importance of coughing and breathing? What else can we do? You might know.
What was the question again? Sorry.
That's okay. So we're talking about breathing exercises. So in adults, we usually want people to keep their lungs expanded by coughing and deep breathing or using an incentive spirometer. But how do we help children to cough and deep breathe? What kind of exercises could we do with them?
Maybe blowing bubbles because they would have to do a big inhale.
Yeah. So the book actually, I believe it has a lot of resources that talk about blowing bubbles or getting one of those pinwheels that spin and blowing it. So there's games that you could do to actually increase lung expansion. And it involves kind of like having kind of lightweight towers and blowing them over and those kind of things. And so that's increasing that coughing, kind of deep breathing to be able to get air all the way down into the alveoli. And then hyposensitization, that means really allergy testing. So being exposed to very small amounts of things that you may be allergic to, and building up those antibodies to those things that you could be having that kind of a reaction to. So hyposensitization can be involved in maybe the doctor referring to an allergist, and they go and they talk about kind of things that are maybe when, of course, when asthma occurs, whether it's a certain time of year, whether they're outside or whether it's exercise, all those things, then they'll give them an allergy test. And it's kind of the pinprick little test where they put drops of concentrated known allergens, and they can do that on an arm, they can do it on the back, and so they can see what the child is having this reaction to, this hypersensitization, if you will. And so the intent is to use the allergens to create kind of an allergy serum that they get administered by the allergist, and it is usually weekly or however often that they think they need this sensitization. And the purpose is to induce that allergen a little bit over time, a little bit increasing amounts, so your body builds up a response to it or builds up an immunity to it. So this hyposensitization is to decrease the body's sensitization and overreacting to these things that they're coming in contact with periodically. Again, it could be a number of different things that go on to cause this overreaction of this asthma symptom when you're exposed to certain type of allergens. Status asthmaticus is a severe form of asthma. So it is respiratory distress, and it continues despite vigorous therapeutic measures. Now, with this, we think about occlusion of the airway, and it could be where someone has had repeated episodes of asthma and they've got worse and worse, or this can occur as a one-time thing where they're exposed to something that they have a reaction to, and they have this complete occlusion. A lot of times we think about this as an anaphylactic reaction when we think about coming in contact with things like peanuts or latex or any of those type of things. But people tend to think it's something that they've never been exposed to, and then they're exposed to it and it happens. But somebody could have a severe reaction to something that they've never had a severe reaction to before. So it can happen at any time. I've known of a lot of healthcare providers that have, back in the day, all we used was latex gloves, and they used them and used them. Then all of a sudden they started having a reaction to them. So you can develop a reaction to something. Our most important thing is emergent, making sure we have an airway. And so emergent treatment could be epinephrine. And this talks about, I got that dosage from the book, but it talks about emergent treatment of epinephrine. And again, it's a catecholamine that it speeds things up, and also bronchodilates, so it opens up the airway. We also look at if somebody has this status asthmaticus, what else is going on with them? So was it an allergic reaction to something? Was it, like it says, a current infection that maybe the infection went to the bloodstream, they became septic, and they started having this reaction of the airway closing. So once you establish that they do have a patent airway, they need to look at what's causing it to be able to determine how to correct it. Is it a bacteria they need an antibiotic? Is it something that they've been allergic to? And so making sure that they are not only continuing to help them to open up the airway and decrease inflammation, but also making a plan of, wow, we need to really be desensitized to that or stay away from that. And then a therapeutic intervention. So again, that's what we're talking about, is what's the cause and how do we intervene in that? Okay. So asthma care, again, if you've ever had an asthma attack or you've ever choked on a piece of food and you've seen your life flash before your eyes, that's kind of the anxiety kind of provoking with asthma. So of any age, but particularly of a child, it's very easy to become anxious very quickly. And we know that anxiety can increase inflammation. And it also, if someone's crying, it can make it more difficult to breathe. So keeping calm, keeping our calm presence, allowing the child to lay in any position they want to, whether it's in the bed or whether it's sitting on the side of the bed or whether it's in mom's lap. We tend to want to, when somebody is having trouble breathing, to say, oh, lay back and let's put your O2 on. But this may be someone that says, or an adolescent or even a school age, or someone that's not sitting on the side of the bed, and we see them in that tripod position and they're trying to breathe. So whatever position they're in, they're getting the best breathing, we'll leave them in that position. But we do want to monitor their O2 stat, put an oximeter on them. If they need it, put oxygen on them until we get them kind of calm And then if they need emergent treatment to open an airway or something like that, then they're not going to be conscious. So, but we want them to stay calm, okay? Many times if we can intervene early in asthma attack, then it's mild. And we can give them medication like a bronchodilator that can open up very quickly the airway and not result in something that's more severe. This is a picture here, and you know, we can see the positioning. So we've got him set up about 45 degrees, got the oxygen mask on. I'm sure they're trying to keep him calm. Many times, like we said, it could be an oxygen mask. It could also be a nebulizer treatment that has steroids or bronchodilators, something like that in it. All right. So a couple of goals we talked about: avoiding things that cause exacerbations. Again, we have to figure out what it is first. Avoiding allergens. So this could be going to an allergist, getting allergy testing. In addition to getting allergy shots or something like that, they would also be able to identify what it is so you could avoid it or decrease exposure. Relieve asthmatic episodes promptly. Again, starting to teach and being able to recognize those early symptoms, okay? So we can treat early. Relieving bronchospasms, so that means having a short-acting bronchodilator with me, an inhaler. If I don't have it, if I don't carry it with me, then there's likely chance that my asthma could get really, really bad before I get treatment. Monitoring functions with a peak flow meter. A peak flow meter just measures the volume of air that you can breathe in. And so this peak flow meter, you can have a meter that measures how much you breathe in, but also how much you blow out. So I happen to have one that is a peak flow meter. It's just a little plastic device, and it's got a green, yellow, red area, and you blow out on it, and it shows how much lung volume that you have. And of course, if you have inflammation of the lining of the lungs, then the ability of your lungs to be able to expand is smaller, so you don't hold as much air. So if you blow, blow, blow till your air's gone and you don't have a whole lot of air in there, then you're not able to really raise that meter as much as it should. So at home, they can use this peak flow meter. And when they're starting to teach people to monitor symptoms, they teach them to use it every day. So you just blow into it and it measures it. And so you can start to realize, hey, that didn't go up very far. I'm kind of in the yellow. How am I feeling? And you kind of equate that with feelings. And then it also is kind of a definitive measure too of, wow, I'm really not doing well and I need to go see the doctor. Self-management, again, knowing medications, knowing how to use them correctly, making sure you don't run out of medication, making sure if it's related to activity, whether it's exercise or going into environments where you're at higher altitudes, where the oxygen portion's lower, things like that, knowing how to manage your asthma, and then how to support the child and the family as well. Especially if we have a child that's going to school, then we also need to make sure that they have instructions and things and in contact with the school nurse. And a lot of providers will actually make a direct contact with that school nurse or have a number for that school nurse to call so they can keep in conjunction with management, medications, all those types of things. Okay, questions? All right. So one of the disorders that's in this chapter and that, of course, I put in our lecture is very important. It's cystic fibrosis. But cystic fibrosis goes much more than just a lung problem. We talked about respiratory first, and so I put it in respiratory. And I think that's where the book introduces it too. But cystic fibrosis is called an exocrine gland dysfunction, okay? And so we think about endocrine and exocrine and all those things with the pancreas because we've talked about those glands and enzymes and things with the pancreas, but there's numerous exocrine glands all over our body. They are exocrine glands that it just means that excrete things on the skin, in the lungs, in the bowel, all over our body. And so this is a dysfunction of those glands. So what it means is the ability to be able to excrete enzymes and the adequate amount of enzymes, there's a dysfunction in it. And so with this, knowing that it's passed in chromosomes, it's actually a mutated gene on a chromosome, and it's autosomal recessive, which means that you have to have two parents that have this recessive gene kind of come together. And so they may not even know they have the recessive gene. It could be further back in their family or something like that. So what happens is the child inherits this defective gene from both parents. And if they have 4 kids, one child, it's kind of a 1 in 4 chance that the child will have both of those recessive genes, one from each parent. And so it's about 3% of the population are carriers, and they don't even know it. It's the most common lethal genetic illness among Caucasian children. And we'll see when we talk about that why is because it's really multi-system. So the pathophysiology, kind of what's causing it, it's an increased viscosity, a thickness of mucus gland secretions. And again, mucus we think about with the respiratory tract, but glands that secrete enzymes are all over our body. And so we think about that these enzymes that we secrete, and we'll talk about what those are, they're thicker. And so which means that the pathway that they usually are excreted can be occluded. And it can exclude things that are downwind kind of from that pathway. And that mucus can get thick and it can sit there and it can cause obstructions of that pathway. So the pathways that we traditionally think of are sweat glands. Okay, we'll talk about that. And so it can also affect sweat. And what we tend to see in that is an increased excretion of things like sodium and chloride in saliva and sweat. And what you hear parents say sometimes is that their child tastes salty. So if you give your kid a kiss or something like that on their skin, what they are kind of sweating or excreting is kind of salty. And so in direct proportion to that, if we're losing sodium, chloride, those kind of things in extra proportions, then our patient, if they're having a lot of problems at that particular time, could particularly have a problem with low sodium and low chloride that they really need. So we'll look at that a little bit more. There's an elevation of sweat electrolytes, and those are sodium and chloride, okay? I love this picture because it kind of talks about the disease as a whole. And so we have that gene defect at the top, and what that means is there's an exocrine gland defect. And so we say, what does that mean? It means there's abnormal mucus secretion and obstruction. So the enzymes or the liquid that should be coming from different portals in our body are really thick, and they refer to them as tenacious, meaning that they're really thick and they sit there. So it can block things that should be going through that pathway. And it can also cause problems with areas past that. So 4 areas, really. The bronchi, okay? So this thick mucus we think about with the lungs. And this part is talking about the lungs. So this bronchi obstruction. So if we think about the trachea and the bronchi come off of each side of it, the thick mucus that should be lubricating the lungs and moving dust particles and things like that as we cough, coughing them up, those type of things, it's actually really thick and it is obstructing the bronchi. Now it can be partial obstruction, or maybe there could even be a total obstruction of one part of the bronchial. So it can cause bronchial obstruction. We know if something's blocked there, what's happening beneath that? So it can cause chronic bronchial pneumonia. Again, those fluid that should be moving is trapping fluid underneath that. And so that can build bacteria in it. And then generalized obstructive emphysema. That has to do with our gas exchange. So if there's a blockage in the bronchioles, then air is not able to, not only oxygen isn't able to get down the way we need it to, but CO2 isn't able to get out the way we need it to. So the alveoli work harder and harder and harder, and they kind of enlarge to try to pull on to as much oxygen, CO2 as they can. But as they become larger and larger, they actually lose the effect of being able to work as well as they can with gas exchange. So we can see problems with gas exchange. We also have enzymes that secrete, or glands that secrete enzymes in the small intestine. So we think about the small intestine, that's used for not only absorption of foods and nutrients, but also of moving stool and waste products along its pathway. So what can happen in the small intestine if that mucus, of course, we think about the child, the very small pathway of the intestines, that mucus becomes very thick and occludes the small intestine, then we can see what's called an inspissated meconium. So what that means is meconium is stool, usually stool that is kind of thick and tarry, particularly equated with the newborn. So how they are producing waste product. And what happens is one of the first indications at birth that they could have that a child has CF is that they have an obstruction of the small bowel. And that meconium, that really thicky stool, it gets stuck in the small intestine. So there's an obstruction and nothing's able to move past it. How would I know that there was an obstruction in the small bowel of an infant? What happens if there's an obstruction of something? Nothing can pass through it, right? So we talked about that an obstruction of the lungs, we can't pass oxygen and CO2. An obstruction of the small intestine, when we try to feed, whether we're bottle feeding, breastfeeding, they continue to vomit, and we don't have any bowel movements. So that obstruction there, that intestinal obstruction of the newborn, we can see. Now we can also see sometimes what happens is that the area distal to that obstruction, the muscles try to kind of start working as the infant's born, but nothing can get past it. So we can actually even see the rectum, kind of an outpouching of the rectum as well. But that meconium obstruction in the small bowel is one of the first signs that we see. Another one is the pancreatic duct. So when we talked about the pancreas, we said it had endocrine and exocrine function, and the exocrine function is excreting pancreatic enzymes that go into the small intestine and break down food. So what happens is those ducts that the pancreatic enzymes go through, the bile ducts to go into the small intestine, get blocked. So number one, I can't get the pancreatic enzymes, so I can't break down food. So I'm at risk of malnutrition. But also those pancreatic ducts start to become very hard and fibrous and inflamed. So that kind of exacerbates the idea that I'm not able to get those pancreatic enzymes in the small intestine, and that can result in malabsorption, okay, because that's needed to break down food. Then we can also see it in the bile ducts. So we said the pathway that is shared not only by the pancreas, but also by the liver and the gallbladder. And so if that bile ducts that they all share becomes very hardened and obstructed, then it affects my liver. And it says focal biliary fibrosis, which means hardening of that pathway, that bile duct. And it causes biliary cirrhosis, which is kind of a hardening or damage to the liver. So damage to the outside of the liver. And also damage to the bile duct. So we can have portal hypertension. And so way back when we talked about cirrhosis, we said that if there is an obstruction either in the pathway or with the liver is unable to do a lot of its function. And one of its functions is to filter all the blood through, right? So we filter the blood through the liver, it pulls out the things that need to be metabolized, and then it gets rid of waste products by sending it to the through the kidneys, right? So if the liver is getting hard and it's not able to do its job, then it builds pressure, and pressure gets pushed on the blood vessels that are trying to filter all that blood through. So if the blood can't be pushed through in adequate amounts that it's coming at it, it starts to backflow. And when it backflows, it can go into other areas that are smaller vessels that come off of that inferior vena cava that goes to the liver. So we can look at things like we said, like ascites. We can look at esophageal varices or bleeding of the esophagus. We can look at edema, all those types of things. And so we see that this exocrine gland dysfunction, cystic fibrosis, is completely multifactorial. Now we'll talk about, there are a lot of things they can do to manage this disease process. We can't get rid of it. It's a gene defect, but we can try to manage it. But really the optimum kind of age, or the end age for someone that has CF is usually about 40. That's really kind of the max age of someone that lives with CF. So signs and symptoms, again, the kind of things we talked about. In addition, also the sweat gland dysfunction. And so what that means is that the ability for us to sweat and regulate really how much sodium chloride we lose, because we want to hold on to it. And so we don't want it pulled out from the blood vessels and being excreted. It's excreted in large amounts. And so hence, it's kind of saltier when it comes out because we're losing too much. And so that can result in an imbalance in what we really need to keep in our vascular system. So from this, we can see things like COPD. Again, we're affecting the bronchioles and the alveoli. Pancreatic enzyme deficiency. We said that. So the enzymes aren't able to leave the pancreas and go down the bile duct into the small intestine. From that, we can get malnutrition, which we see in weight loss. They're hungry, but they're losing weight. Gradual respiratory deterioration. The more inflammation, the more blockage, the more repeated infection, the more hardened or scar tissue forms in the lungs. And it becomes harder and harder to get those deep breaths and get oxygen down to the alveoli and gas exchange back out. Let me back a little bit. Failure to thrive on here, it means that even with the infant that we're feeding and we're trying to get nutrition, but they're just not growing. We're looking at growth, we're looking at development. They're lagging in growth and development, mainly because they can't get that nutrition in through the small bowel. Okay. So what does it look like? We're seeing symptoms in all these areas. So respiratory-wise, wheezing, dry, non-productive cough. Dry and non-productive because it's so thick, right? We can't cough it up. Obstructive emphysema, again, it's blocking oxygen and gas exchange. So the alveoli start to become enlarged, and that's what's really indicative of emphysema. It's not working as well for gas exchange. Patchy atelectasis. So what that means is that atelectasis is the alveoli that are not being able to do their job. And we can also see atelectasis when we look at a chest x-ray. We can see the bottom part of that atelectasis. Instead of looking like tiny little grapes, it looks like it's really edematous. Cyanosis, no gas exchange, right? Or poor gas exchange. Clubbing of the fingers and toes, indicative of a chronic respiratory problem. And then bouts of bronchitis, pneumonia, because we're trapping bacteria down in the lungs. Okay? Meconium ileus, we said that was the first symptom that we're usually going to see is at birth, because that meconium, that infant stool, those first stools they should have are already thick and they're forming obstruction. And we notice that when we start to try to feed, and they're vomiting and they're not having any stool output. Prolapse rectum, that's what I talked about before. So even though the food and things aren't going past that blockage or that obstruction of the small intestine, we still have peristalsis, right? So that peristalsis that's moving the muscles beyond that, even though it can't move the obstruction, is pushing. And so that rectum can actually be prolapsed or kind of pushed out because of those muscles that are trying to kind of work overtime to kind of move that out of the small bowel. Distal intestinal obstruction syndrome. So again, if we get rid of that initial meconium ileus, they can continue to have these intestinal obstructions that occur. Excretion of undigested food. So what it looks like when someone has problems with malnutrition or malabsorption, sorry, I meant malabsorption, is that they're taking in the food, but we don't have the enzymes to kind of break it down and use it. So we're not breaking down fats and carbs and all those kind of things that we really need for energy and for storage. And so they're being passed out in stool, and the stool looks really fatty. It can either have kind of white fatty parts to it, or it can be very foul smelling and, like it says, kind of frothy, meaning that a lot of that kind of loose fat is passed out as well. And that's referred to as a steatorrhea. Then wasting of tissue. So even though I'm taking things in, I'm not getting things to use for fuel. So basically I'm just burning the things that I have on me. I'm using more energy than I'm taking in. Okay? More fuel.
How do you spell that?
Steatorrhea.
Yes.
Steatorrhea. Steatorrhea. I think so.
Okay, thank you.
So if we're not getting enough nutrients, if we are having slowing of growing and developing. We can see a short stature. We can see problems with fertility, males and females. We can see a delay in puberty. Okay. Again, the salty excretion on the skin. Parents may say, that they notice that. They can become dehydrated. Again, we're not taking in and holding the things that we need. And so again, we can be moving things through as well as fluid and not being able to pull out the things that we need to hold on to. Low sodium, low chloride. So what happens is that we begin to have kind of a metabolic alkalosis going on because we're losing a lot of those things as well. And then low albumin, hypoalbuminemia, mainly because that albumin, again, is produced as a protein that's in our blood to carry around all the oxygen and all those kind of things. And if we are losing some of these other proteins, some of these things like sodium and chloride and those kind of things that are traditionally used to help in the production of albumin, we don't have enough. In addition, we said that we may be low on albumin because the liver isn't doing all of its job. And one of its jobs is to produce proteins like albumin. And so if we don't have some of the products to make it, in addition to the liver being able to metabolize, then we're not making enough albumin. And we know if we don't have enough albumin, fluid doesn't stay in the vascular system and it starts going into the extremities, third spacing. Okay, so abdomen, extremities, lungs, heart, face. So how do we diagnose it? One of the really definitive tests is called a quantitative sweat chloride test. And quantitative means amount. So we're testing the amount of sweat, sodium and chloride that's in sweat. Okay, and so they do that to be able to see if that's one of the signs that they have. They're also going to do a chest X-ray, and they're going to look for signs of inflammation as well as the amount of mucus. Pulmonary function tests not only tell about some obstructions or partial obstructions, but they tell about how much expansion that you can have. And if we have this mucus, it irritates the lining and causes inflammation. So we're not able to expand and take big, deep breaths due to the mucus and the inflammation. So pulmonary function tests can tell how much I can take in, how much I can blow out, how hard I can blow out, which means how fast that I can get air all the way from the bottom to the top. They're going to look at stool. They're going to test stool and then test enzymes, pancreatic enzymes, those type of things, enzymes that are located in different parts of the body to see what their consistency is. So to see how thick they are, how viscous they are, what they're made of. And then they can even do what's called a barium enema, which is where they, barium is a material that we've talked about that you can either drink it or do an enema. And what it does is it kind of lights up fluorescent on an X-ray, and they can do an enema and inject this barium throughout the intestine, and it can light up and it can show any areas that are inflamed or obstructions or anything like that. So they can do a couple of things to really look at where are the problems and how severe are the problems. Respiratory we talked about. So respiratory, this is present in almost all CF patients. But the onset of that and how severe it is really depends on the child, and it depends on a lot of other factors as well. So some of the things that we think about to decrease the effects of chronic respiratory problems are to be able to take medications adequately, to be able to kind of open up the lung fields. So those things we talked about of using that percussion to break up the mucus, to leave the airways more open, to the things like blowing on the pinwheels or blowing on other types of things to take those big deep breaths to help expand the alveoli. And then knowing that if they have that mucus that's stagnant in there, we're not doing something to help liquefy it by staying hydrated and move it, then more infection, more bacteria is going to form past that, and then that can lead to scar tissue. It does progress with respiratory wise, and gradual progression again is that scar tissue that's forming. And so the more infections, the more scar tissue, and the harder things become. The bronchial epithelial, the skin or the mucous membranes that are on the inside of the bronchioles, they become destroyed. And so, and other things that we think about of it's so important for those mucous membranes down in the lungs is cilia that traps dirt and bacteria and kind of gets irritated and makes us cough. Well, that's destroyed too. So things go down to the bottom of the lungs more easily, and we can't get them back up as easily. That infection, we say, can spread, and it causes that peribronchial fibrosis, that hardening of the bronchiole, so that when we are trying to take those big deep breaths, and those muscles that are surrounding our airways try to help accommodate us by expanding or bronchodilating, we can't do that anymore. So even if they get narrow from being harder, we try to do something like use a bronchodilator, this doesn't work because the muscles and the tissues are damaged. So they're permanently small. So we have an even increased risk of an obstruction and poor gas exchange that we really can't fix. Further respiratory progression, chronic hypoxemia, low oxygen in the blood. And it says it causes contraction and hypertrophy of the muscle fibers. That's on the outside of the bronchioles. So this contraction of the muscles on outside of the bronchioles makes the airway smaller, and it's in the it's surrounding the arteries and arterioles as well. So, you know, like I said, even if we were to use systemic medication like steroids to open up, it's not able to do that. Even though it's able to try to get into the blood vessels that feed into the lungs are hard. It's not going to be able to open up. Pulmonary hypertension. So we talked about that pressure that is coming from the lungs that's backflowing into other places. So particularly cor pulmonale, and those things kind of go hand in hand. So cor pulmonale, way back we talked about, was right-sided heart failure. And so in addition to that, if the right is kind of working really, really hard to push toward this heart to get fluid back up, back out, and the lungs are really fibrous and they can't be pushed to the lungs, then that pressure and that fluid back up in the right. And then what happens is blood flow that's trying to come in is backed up. And so it's backed up in the body. And that's where that right side of heart failure, we can see edema in the body. And that's really compounded by that lack of albumin from damage to the liver. So we see a lot of edema. Pneumothorax is when we have fluid that gets around the pleural cavity of the lungs, and it can cause inflammation and irritation. It can cause pressure on the lungs. It can even cause the lung to collapse. And so with a pneumothorax, if the lung collapses, they may have to put in a chest tube to help kind of pull out any of the fluid that is in that area, whether it be mucus or blood or just simply fluid that is third spaced, and to help expand that lung on that side. And then hemoptysis from irritation in the lungs and the bronchioles. Hemoptysis is coughing up blood. And it could be either from coughing up the inflammation, but we also said we had esophageal varices likely from that pulmonary hypertension. So let's see how far I am. Okay, we still have quite a few to go. So I'm going to stop here, and I'm going to start back. I think CF is really kind of fascinating, multifactorial. I am pretty sure, I'm about 93.5% sure that I have a case study with CF. I tried to find it. I can't find it. I think it might be on my other computer or something, but I will find it. And so what I'm going to do is post it, have you guys look at it, think about it, and then when we get back together on Monday, I'm going to finish this part and kind of talk about a little bit of that case study as well, because I think it has a lot of symptoms, interventions, those kind of things. And if we do that case study, they'll kind of all come together. Okay. Any questions? All right. I will await your emails with any questions, comments, concerns, and I will see you on Monday.
Thank you.
Thank you.
Thank you.